Yeah, there's an HDMI. I've got a dongle
I have a dongle
for this.
too for an
Oh, yeah.
HDMI.
Can you like test out your laptop or?
It's
Or you
probably a
can-
good idea too.
Yeah. Or if you want to put it on his, whatever. Is easier for you.
Doesn't really matter. I brought USB and laptop, so I could go either way.
Yeah, we can try your laptop out.
Okay.
Yeah, let's do this.
That way you just you know it runs.
Yeah, exactly. Yeah,
Although thankfully that hasn't been
an issue.
a big deal in recent years.
I always get a little nervous, like when I use my own laptop. Like, what's gonna pop up on this?
Oh, I know,
Like,
right?
I'm like, you know, am I gonna get like a ridiculous text message?
Yeah. Oh yes. Yeah. Because you have like iMessage on there, right?
Yeah.
Yeah.
Oh, that's fine.
Yeah. It hasn't happened, but it's just
Yeah,
one of those things I'm a little paranoid about.
Someone yesterday was getting little like notifications, like throughout their talk, and you just hear a little boop every once in a while.
Yeah.
Oh, that's why it's.
But he had to have sound on because he's a
Gotcha.
laryngology lecturer.
Gotcha.
I assume neither of you need sound.
No.
Okay.
We like silence.
Yeah. Yes. If you,
right? If you need a California
oh, sorry.
headphones.
If you need to.
I'm sorry. That means it's on?
Yep.
Okay. Good morning. Welcome back. Excited for our second day. Just a reminder, today we're just meeting in the morning, so there's going to be a chance for you guys to get out a little bit and enjoy the beautiful southern Arizona desert this afternoon. But we will have lunch, so after the end of this morning session, please get some lunch and maybe eat outside, and then activities on your own. If you want to do the hike, please let Sonia know. And those of you who sign up for the golf, we have bag lunches for you so that you can go quickly and get going by 1 o'clock. Another reminder, so hopefully you all have downloaded the app, and that's how we're asking you to give us your feedback on the sessions, and as well how you'll get your CME credit. Another reminder about the scavenger hunt. Stay tuned for answers to your questions, and even if you don't know all of them, I was just reading the directions more carefully. For every 5 correct answers, you get 1 entry, so you still have a chance even if you can't get all 20 answers. Otherwise, without further ado, real excited for the first session this morning, which is going to be on otology, and so I'll turn things over now.
Thanks, Steve, and welcome everybody to the second day of ENT in the Desert and our first Otology session. I'm happy to introduce our first presenter, Dr. Heather Kaufman, who's a clinical assistant professor here at the University of Arizona with expertise in otology. She's going to be talking about Otalgia. So Heather, take it away.
Thanks. Yeah. Thanks. Welcome. Thank you. Yes, I'm going to talk about Otalgia this morning, and I'm not sure what's worse, a 7:30 talk about Otalgia or an Otalgia patient, but unfortunately you have to be here for the first. So we'll start with a patient that I put together. So we'll start with a 57-year-old woman who comes to my office in a business suit. She's here with right-sided ear pain that started 8 months ago. She's tapping her foot, kind of annoyed because I'm running late as usual, and she needs to get back to her important job at the DMV. She describes her ear pain as constant, deep pain that's just below her ear, no cause, no associated hearing loss, tinnitus, drainage, or infection. She never had ear problems before, no tubes as a child. When I ask her, she states she does not grind her teeth, she has no TMJ problems, no anxiety or stress in her life. So what's her story? When you have a patient with Otalgia, it's important to ask pain questions, like what's the character of the pain? Is it sharp? Is it stabbing? Is it all the time? Is it there all day long? Is it there in the morning, at the end of the day? What makes it worse? What makes it better? Associated ear symptoms, hearing loss, tinnitus, fullness, ear infection, head and neck symptoms. Does she have sinus infections? Is it allergies? Does she have swallowing problems? Does she have lymphadenopathy? Any problems with her jaw? And then associated B symptoms. What does it look like? So we definitely want to do an ear exam with our microscope, tuning fork, and then a full head and neck exam. We're going to want to look at her nose, we're going to want to look at her throat, feel her face, her neck, and check her TMJ. Endoscopy if indicated, and we may want to order an audiogram and some imaging. So fingers crossed that this is going to be primary Otalgia. So primary Otalgia is pretty obvious on exam. Most of the time it's associated with other otologic symptoms such as hearing loss, tinnitus, and otorrhea, and most of the time this is infectious. So we're going to look at the ear from the outside in and just go through some primary Otalgia causes. So starting with the auricle, this could be a subperichondrial auricular hematoma. So that's when there's collection of blood between the cartilage and the perichondrium. And when this happens, if it's a big enough collection, we're going to need to drain this. And if that collection's big enough, we'll want to bolster it so that collection doesn't occur again. And if this recurs over and over again, we could get a cauliflower ear. Other infectious causes could be a perichondritis or a chondritis. And this is typically due to Pseudomonas, and we treat this with oral antibiotics. A relapsing polychondritis is a complicated, difficult diagnosis. This is an autoimmune disease causing inflammation of many different types of cartilage. It affects the ears, nose, larynx, and it causes elevation of inflammatory markers such as ESR, CRP, and ANA. And often this requires a biopsy, but the timing of this can be difficult. Treatment includes NSAIDs, steroids, and sometimes dapsone, and we need to refer these patients to rheumatology. In this picture here, the patient is affecting their ear and their nose. You can see the saddle nose deformity. But in all cases of like an infection or relapsing polychondritis, you can see the ear is affected, but the lobule is spared because it's only affecting the cartilage. Skin lesions, this is the chondrodermatitis nodularis helicus. So this is this benign lesion on the ear, but if you are concerned, you can always biopsy this. But in this case, this is a benign lesion. It's firm and very painful. It's from chronic trauma. Classically, this will be a person who always sleeps on the one side, and the pressure compromises the local blood supply. So for this person, you could give them a donut pillow so that they can alleviate that pressure, and rarely this would require a steroid injection. As we move in, we all know acute otitis externa can cause some pain, a foreign body in the ear, external auditory canal cholesteatoma. Usually this looks like just wax in the ear, but as we remove this wax, we see that there is some erosion of the canal. Typically this will just require routine debridement, but sometimes we may need to resurface the bony canal to smooth that out so that it doesn't keep having erosion of the bony canal because of the keratin debris. Bullous meningitis is an infection of the tympanic membrane itself, forming bullae or blisters on the tympanic membrane, as shown here. These can be very painful, sort of more painful than expected, typically treated with the routine antibiotics seen with acute otitis media. Sometimes tympanocentesis or a lancing of these bullae can help with the pain. Herpes zoster or Ramsay Hunt is that latent zoster infection affecting the geniculate ganglion. Pain, facial paralysis, and vesicles in the ear canal are the classic symptoms. And then we treat this with valacyclovir and prednisone. And the prednisone can help with that long-term pain that we could get with the herpes zoster infection. And then necrotizing otitis externa is that infectious case that affects the external auditory canal and skull base. It's usually Pseudomonas, and it affects our patients that are immune deficient and diabetic. Now we do imaging with CT and MRI scan. We treat these patients with IV antibiotics and drops, and we debride patients who just don't seem to be getting better or have progressive cranial nerve deficits. When it affects the middle ear and mastoid, a traumatic injury, that tends to be obvious. Acute otitis media, especially with a bulging drum like this, can be very painful. Sometimes these patients will end up auto-perforating. Chronic otitis media does not tend to be as painful. Even with a draining ear, these patients don't tend to come in complaining of a lot of ear pain. Same with inner ear and petrous apex lesions. Most cochlear and labyrinth disorders don't have associated significant pain, like a viral labyrinthitis, sudden hearing loss, or vestibular schwannoma. One painful disorder to think about is petrous apicitis. So this is a patient that tends to have an aerated petrous portion of their mastoid bone, and a mastoiditis can extend into that petrous portion, and this can be painful. And as we remember, when it extends to the Dorello's canal, which is cranial nerve 6, and it involves the inferior petrosal sinus, that is Gretanigo syndrome with the lateral rectus palsy, otorrhea, and retroorbital pain. And then just to plug in, any new severe otalgia with sensorineural hearing loss and vestibular symptoms, this is atypical and very concerning. So we should just get imaging to rule out any malignancy or vascular abnormalities. So for our patient, she did not have any abnormalities on her ear exam, which she was very surprised about and did not believe me. So I had to explain to her that there are many nerves that innervate the ear, and so I went through this with her. So cranial nerve 9 innervates the ear, as well as the tonsil and the pharynx. So this is going to innervate the middle ear and the tympanic membrane. 10 is going to innervate the pharynx and the larynx, but also the eardrum, ear canal, and the inferior concha. The auricular temporal nerve, it innervates the, it's going to innervate the external auditory canal, the tragus, temporomandibular joint, and the preauricular region. And then cranial nerve 7 is also going to innervate the tympanic membrane, ear canal, and the superior conchal bowl. And then the C2, C3 is going to be through lesser occipital nerve and greater auricular nerve, is going to innervate the entire pinna, a mastoid area, and then the scalp, along with extending down the neck. So there's significant referred pain regions to supply the ear, and many regions around the neck, the head and neck region, and down to the in through the neck and in these regions. So I explained to her that there could be many different areas that are referring to her ear. She was skeptical. There's some quotes that go along with this. So Paparella and Jung say that about half or more of patients with Otalgia have some other reason for oral pain called secondary Otalgia. Kutila states that in less than 50% of adults with Otalgia, is it possible to diagnose ear disease? Leonetti states the most common cause of referred pain with a normal appearing ear is dental or TMJ origin. And Kaufman states that less than 10% of patients with TMD problems believe you when you diagnose them. So we're going to go ahead with TMD disorders. Referred pain through auricular temporal branch of the trigeminal nerve. This is pain involving the masticatory muscles, temporomandibular joint, surrounding bony and soft tissues. The problems involving the masticatory I just said that, sorry. The prevalence of temporomandibular disorder is very high. It's greater than 5% of the population. Kutila, and Nima studied a group of patients. They were 25, 35, 45, 55, and 65, and they studied this group of patients over 2 years. They found that the age of the temporomandibular disorder increased until patients were in their 50s, and then it decreased. And they found that patients were twice as likely to be women than men. And then risk factors for TMD included chronic and repetitive trauma, bruxism, jaw clenching, malocclusion with poor fitting dentures, and the loss of their molars. And just to review, our muscles of mastication are the temporalis muscle, and then the masseter muscle, and then the two internal muscles are our lateral and medial pterygoids. Signs and symptoms are decreased mandibular range of motion, pain in these muscles, a joint pain, noise with function, and then limited or deviation of the jaw when we move it. And Otalgia is seen in greater than 60% of the patients with temporomandibular joint. It may be the only manifestation of temporomandibular disorder. It's the most common sign of patients with temporomandibular disorder. These patients who have temporomandibular disorder and Otalgia are more likely to have tenderness on exam, and they sometimes have otologic symptoms such as oral fullness, dizziness, tinnitus, and even perceived hearing loss. There are two different groups, or they divide temporomandibular disorder into two different groups, the non-articular or extracapsular, and then articular intercapsular groups. The non-articular groups are going to be these muscular problems that we can see and help, and that's greater than 50%. This is the myofascial pain and the muscles of mastication with the clenching, the bruxism, spasms, and pain, and it can be worsened by stress. And then the articular disorders are the inflammatory, the rheumatologic process, and then the non-inflammatory like the osteoarthritis and the joint damage from trauma. We diagnose these patients with a history and physical, pain with the joint and muscle movement and palpation, and the limited range of motion. Dentists can help out by getting the radiographs of the teeth, and the CT scans help show the joint and bony structures, and the MRIs focus more on the articular discs. Treatment, we can do non-surgical therapy, which is effective in 80% of patients. It's really important, especially for these ear pain patients, that we explain and reassure that yes, your ear pain can be because of your TMJ, and that we can help you. The front part of your ear is the back part of your jaw, and so these two are really linked. It is important that they need to work on reducing the stress on their temporomandibular joint and their masticatory muscles. So I tell these patients they need to have, at least for 2 weeks, a soft diet, try not to clench and grind, and then massage and heat the external muscles, and just do active relaxation when they can. If patients can tolerate it, scheduled NSAIDs. So I recommend ibuprofen, 400 or 600 milligrams 3 times a day, not with pain, but scheduled. And then I like these 2 jaw exercises. So the isometric jaw forward thrust, so pushing their jaw forward and putting their hand on it and holding it for 5 seconds, doing that 5 times in a row, 3 times a day. And then there's another one where you open the jaw and then push the jaw closed, again holding it for 5 seconds, 3 times a day. And these 2 pictures are from Up to Date. So, and it has a little explanation paragraph. If these patients come back and they feel like it helped, but it didn't completely resolve, or if they're still having symptoms, I like to send the patients to OMFS. They can do splints, physical therapy, Botox, and some patients even need antidepressants and behavioral therapy. So I tried this with this patient, said, definitely TMD, you need to do this. Unfortunately, she reluctantly tried the medical management for 2 weeks, and triumphantly, she comes back and tells me it did nothing for her. However, she was slightly less hostile, and she did let me know that during her college cheerleading career, she was dropped on her head, which caused chronic neck and back pain, which she did not tell me at our last visit. So now we're going to talk a little bit about the zebras of otology. So dental pathology, this is referred pain through the auricular temporal branch of the trigeminal nerve. Most often it's due to our mandibular molars, and this could be dental caries, gingivitis, abscess, but also from excessive brushing and then erosion from acidic substances. And we want to send these patients to the dentists or endodontists. Upper airway could be referred pain through the glossopharyngeal nerve. So we're going to think about tonsillitis, paratonsillar abscess, or pharyngitis. So in this picture, we have an infected tonsil or paratonsillar abscess. And the most important diagnosis that we do not want to miss is a head and neck malignancy. And in greater than 50% of patients with nasopharyngeal carcinoma, they have Otalgia, which is much more common complaint than in hypopharyngeal carcinoma or oropharyngeal carcinoma. So if we don't know the diagnosis right off the bat, it's important to do endoscopy in Otalgia patients. So here we have an obvious tonsillar carcinoma, but if it's not obvious, we may need to scope these patients. If you do find anything, obviously working up with imaging and biopsy. Eagle's syndrome is that elongated styloid process greater than 30 millimeters, more common in women and most common in the 20 to 40-year-old age group. The symptoms are dysphagia, dynaphagia, and foreign body sensation. The cause is unknown, but it's thought to be maybe a styloiditis that comes after a severe infection or a tonsillectomy, and it may be a vascular or nerve impingement. In this case, you can see the really long styloid process in this patient. And then on physical exam, when you palpate the tonsillar fossa, they may have pain, or if they've had a tonsillectomy, you may even be able to feel the styloid process. We want to get a CT scan or a 3D recon. As you can see here, these styloid processes are very long. And for some patients, they may be interested in a surgical excision, either transoral or an external approach. The larynx or esophagus, this is referred pain through the vagus nerve. So we may be able to scope and see some laryngitis, reflux. For some of my patients, I'll just do a trial of Pepcid for a month just to see if they have any improvement. And then hiatal hernia is something to keep in mind, and we would probably have to send them to GI for an EGD or consider a barium swallow. Cervical spine, we could have referred pain via C2 or 3 through greater auricular or lesser occipital nerves. Al Shekli did a study on 100 patients, and 22 of these patients had cervical spine pathology causing their ear pain. So degenerative disc disease can be a problem, arthritis, disc herniation, facet disease, and spine stenosis. So the constant retroorbital or infraorbital pain could be coming from our spine. So patients, we want to send these patients for MRI scan if they have proven disease, physical therapy, or sending them to a spine specialist. In this example, the patient has foraminal stenosis due to a large osteophyte, and this patient had complained about right-sided ear pain. And a parotid gland could cause problems, and this is through the auriculotemporal or greater auricular nerves. So bacterial parotitis is unilateral parotid swelling, most often elderly and immunocompromised patients, precipitated by dehydration. We think about Staph aureus and Pseudomonas, and we want to treat these patients with antibiotics, increased hydration, and sialagogues. Another one to consider is mumps. This is bilateral parotid pain, and Otalgia can actually precede the facial swelling. This is caused by paramyxovirus, and classically our kids are getting vaccinated for this, like at 12 months and 4 to 6 years, but there's actually been a resurgence in this. Mumps have increased, especially in our teen and young adult population. In 2016, there was a 2 times increase in the incidence of mumps compared to the past 5 years. Su, Chan, and Chen did a study in 2020, and they demonstrated a waning of our vaccines. And then in the Journal of Infectious Disease that same year, they demonstrated a 3rd dose of MMR increased antibody levels and improved immunity against mumps. This has not been added to a routine vaccination schedule yet, but it's something to consider. The thyroid can refer pain through the vagus nerve. Subacute thyroiditis or decurvans is a painful inflammatory thyroid, and the pain can radiate up to the jaw and the ear. Patients are fatigued, they have myalgias and arthralgias. 50% have thyrotoxicosis symptoms and have hypothyroidism. Most of the time it's just 1 to 2 weeks, but it can extend out, and we treat the patient supportively, but some need prednisone and beta blockers for their thyrotoxic symptoms. And for those patients, they should be followed until their thyroid levels are normal. Neuropathic pain, so that's that sharp stabbing pain in the ear that can last seconds to minutes, and it often is repetitive. So these patients can have sharp pain 20 times a day, and then in between attacks it might be mild. Sometimes they'll have periods where it's really bad and then periods where it's not so bad. And some examples would be based on the nerve. So the trigeminal nerve is tic douloureux, and this would be pain in the face, lower jaw, and they may have facial spasms. The glossopharyngeal nerve will be pain in the ear, tonsil, and back of the tongue. And then nervous intermediate is going to be really deep in the really deep in the ear. And then they all have triggers. So trigeminal nerve is going to be maybe light touch and certain trigger zones on their face. The glossopharyngeal would be like chewing, swallowing, maybe certain touches, certain tastes or touching on their neck or ear. And then nervous intermediate is going to be touching in their ear or maybe a cold temperature in their ear. On exam, the exam is normal and there's no TMJ abnormalities. But it's important that we check MRI scan to rule out any masses or vascular abnormalities in these patients. Treatment for these patients is anticonvulsant medications like carbamazepine or oxcarbazepine, and then if these don't work, gabapentin. For patients that are not responding to medical management, microvascular decompression is an option. And then myofascial pain is a regional pain syndrome with sudden onset and local trigger points. So these trigger points are hyper-irritable nodules that are actually palpable on exam within the skeletal muscles. And when you palpate them, they can actually cause the referred pain and tenderness. The pathophysiology is really extensive, so it's like poor posture, trauma, but like vitamin deficiency, anemia, and stress. And the prevalence is up to 7% of the population, so a really big group of patients, much more common in women. W.S. Tichy did a study or did a paper that talked about every different region in the head and all the symptoms, but the ear symptoms were pain, like a pressure in the ear, foreign body sensation, hyperacusis, hearing loss, tinnitus, dizziness, but all the studies were normal, like the audiogram, the tympanogram, any vestibular studies, they were all normal. And according to him, it's important to recognize it's not temporomandibular disorder, it's not dental occlusal irregularities, that it's a myofascial dysfunction and it's the masticatory muscles. He said it's really important to note that you're educating the patient on the precipitating factors. So if they're sitting all day long at their computer, hanging out like this, that they need to get better posture and then institute a home stretching program. And they need to deactivate their trigger points. And so a physical therapist that's educated in these trigger points and the therapy for this would be really important for them. And they may need to have occlusal splints. Patients that are refractory to this type of treatment may need to have cognitive behavioral therapy, tricyclic antidepressants, or muscle relaxants. So in our patient, she ended up having an MRI which demonstrated C2-3 disc herniation. She ended up going to physical therapy and had significant improvement. She never came back to see me, but I'm sure you've noticed a significant improvement when you go to the DMV. My take-home points are that the physical exam will tell you if it's primary otalgia. Secondary otalgia is TMD until proven otherwise, but to try that medical management first. And then to look for secondary causes with your history physical exam. And make sure to rule out malignancy with endoscopy. And then you may need to refer out for management. Did anyone have any questions? Yeah. If they get dizziness? Oh, I'm not sure why that would be caused by temporomandibular disorder, but I think that, I'm not sure that I said it was dizziness in there, but I think I said that there was possibility of tinnitus and hearing loss. I don't know how you can explain it, but I think that if you treat the temporomandibular disorder, I think I mentioned that there was tinnitus and hearing loss and fullness. Sometimes those actually improve. I'm not sure about the dizziness for it, but yeah, sometimes patients do come in with all of those symptoms. But the explanation might be just the fullness that they feel because of the temporomandibular disorder. I can't explain the vertigo that they may experience with the temporomandibular disorder. But patients do have all those symptoms together some of the times. If that patient had temporomandibular disorder and they had dizziness, but my exam was normal, I may end up sending them for vestibular testing. Yeah. Probably. I might come up with something. I might have to say something like rule out malignancy or something like that. But I do think it's important because at some point, if I find nothing on my exam, I will say something like, you know what, I'm going to get a CT or MRI scan just to be sure. It's also for myself because if there's not an underlying cause that I'm not catching, if I've done everything and I've scoped the patient and we've done all these, and we've tried things like we've tried Pepsid and we've tried, we've done the temporomandibular joint, all the medical management, and they're just not having any improvement and they're really suffering, I probably will try either a CT or MRI scan, and I probably would try to say something like rule out malignancy or something like that, just to be certain that I'm not missing something that's underlying. Usually I can get away with it. There's some that are terrible, and I have to call them. Yeah. We don't tend to as much anymore. We tend to stick with just the CTs and MRIs, but that was what we did historically. Thank you.
Thank you, Heather. That talk was great. It just took you walking over, Chris. All right, good morning. Nick Duyer, neurotologist here at the University of Arizona and director of the Otology, Neurotology, and Skull Base Division. And I'm going to be talking about pulsatile tinnitus this morning. And I'm excited to be talking about this topic because, one, it can be really challenging for clinicians to figure out how to go through the differential diagnosis and figure out what this might be. And secondly, because there are some new developments in the field. So, no disclosures. And my objectives this morning are, after this talk, that hopefully you'll have up-to-date knowledge of the differential diagnosis for pulse synchronous tinnitus, understand which imaging studies are useful for the workup, and be aware of treatment options for select causes. So we talked a little bit about why this is important, and here I've also listed a couple of the new developments in recent years that I think are good to be aware of. One is superior semicircular canal dehiscence, and the second is this syndrome that includes sigmoid sinus wall anomalies, transverse sinus stenosis, and intracranial hypertension. And we're going to talk more in depth about those later. But let's start with some definitions of tinnitus so that we're all on the same page. So first of all, pulsatile, non-pulsatile. I think that this one's fairly straightforward in that your run-of-the-mill routine tinnitus, someone comes in and they have constant ringing, buzzing, roaring, static, something like that, is non-pulsatile tinnitus. Whereas pulsatile tinnitus is something that in short succession has a staccato kind of pattern or something similar to that. Within that group of pulsatile tinnitus, you can then separate it into pulse synchronous and non-pulse synchronous tinnitus. So pulse synchronous tinnitus means it matches up with your heartbeat. If you put your finger on the patient's pulse and you ask them to tell you when they hear the beats, it's at the same time that you feel their pulse. Non-pulse synchronous tinnitus, the example that comes to mind most easily for me is somebody who has a middle ear myoclonus situation where they get the muscle spasm, they get fluttering in their ear that's staccato, but it doesn't match up with their heartbeat. And then finally, subjective versus objective tinnitus. Subjective tinnitus is something that we cannot hear as the examiners. Objective tinnitus is something that we can hear, either by getting close to the patient or using a stethoscope and auscultating in particular places. So this is a table out of Cummings that lists the differential diagnosis for pulsatile tinnitus. And if you look at this, it's a long list, and there's a very broad range of possibilities that include multiple body systems, including many things that we're not necessarily expert in. So at the top of the list, we've got hypertension, valvular heart disease, Paget's disease. You've got temporal bone tumors, carotid artery atherosclerosis, temporal bone abnormalities, venous abnormalities. It's a very long, diverse list. And so this is one of the reasons that I think that this topic is challenging for us as clinicians to try to figure out what's going on and help the patients. So this is how I try to think about the differential diagnosis for pulse synchronous tinnitus and to try to make sense of all these different possibilities. So in my experience in clinic, if somebody comes in and they talk about hearing their heartbeat, the most common thing that I see is that they have a conductive hearing loss from something, wax, a middle ear effusion. And this is stuff that we tend to be pretty good at and can be pretty simple to figure out. There's also the category of what are the most dangerous conditions on that list that we want to make sure we're thinking about not missing. And these are things like arterial vascular problems, like carotid artery stenosis, aneurysm, which I think is a little bit debatable about whether that actually causes pulse synchronous tinnitus, and dural arteriovenous fistulas. And then finally, there's the other category, which you can separate into, is it coming from the ear or something else? And also, is it something that's correctable or not? So let's go through a list of possible causes for pulsatile tinnitus. And after going through that list, I think it becomes a little bit easier to wrap your head around what imaging studies you might need to do and what steps you would need to pursue in your workup. So we mentioned a little bit of conductive hearing loss, or we mentioned that as a common cause of this. So this is stuff as otolaryngologists that we're very familiar with, is that somebody comes in, they say, oh, my ear's kind of full, I hear my heartbeat in it, and you look, and they've got middle ear effusion. And many times we're getting audiograms for patients with ear complaints, and you see a conductive hearing loss. So I'm not going to talk a whole lot about this. Dangerous vascular causes. And so we talked about these: carotid stenosis or dissection, dural arteriovenous fistula, arteriovenous malformation, aneurysms. These are things that tend to be outside of our realm of expertise as otolaryngologists, but they're things that we at least need to think about with pulsatile tinnitus patients or pulse synchronous tinnitus patients. Third window phenomenon. So this is one that I keep an eye out for because I think it's oftentimes missed, and this is something that we do have expertise in. So third window phenomenon, typically there's two windows into the inner ear. There's the oval window where the stapes sits and the round window. And conditions where there's an additional opening to the inner ear space, we now know very well creates this set of conditions or this set of symptoms in some patients that we call third window phenomenon. The most common third window that we see is superior semicircular canal dehiscence. And this presents with what I'll call a pseudo-conductive hearing loss many times, in that if you get an audiogram, as this one shows here, it looks like there's a conductive hearing loss in that right ear. And the actual mechanism of it is that there's sound that gets shunted out. And so I call it a pseudo-conductive hearing loss, but essentially that's what you see on your audiogram. They can have auditory symptoms that fall under the category of bone hyperacusis, which is essentially hearing body sounds louder than you should. So some patients who have this, if you ask them, can you hear your eyeballs move in your head? They will say yes. They hear their voice abnormally loud. Their footfalls on footsteps feel abnormally loud in one ear. And you know, stomach grumbling, things in the body that shouldn't be so noticeable can be more prominent in an affected ear. And then they can also have vestibular symptoms, which most often include sound or pressure-induced vertigo. And so some typical things that they might say are that when I sneeze or cough, I get a momentary shift in my vision. Or you know, if I'm straining while exercising, I notice that I start to feel a little dizzy. This can be diagnosed well using a combination of a CT temporal bone and VEMP testing. And surgery can be effective for symptom relief in patients who are sufficiently bothered by it. Then there's a category of temporal bone anomalies, and these include things like aberrant internal carotid artery, persistent stapedial artery, cochlear carotid fistula, dehiscent internal carotid artery. These are things that oftentimes you can see on a CT temporal bone, and by and large, they're not dangerous and they're not correctable. So if you find one of these, you can reassure the patient. You know, you can give them some advice that, you know, if they have like an aberrant internal carotid artery like you see on the CT scan that's running through the middle ear, that people should stay away from trying to put ear tubes in that. But in general, this is sort of a reassurance, and maybe if they're really being driven crazy by this, you can think about things like cognitive behavioral therapy to try to give them some coping mechanisms. I have a note here. So this is one that comes up every once in a while, and I'm not sure where this really got propagated for knowledge, but it's pretty common to see radiology reports that will comment on an intravascular loop on an MRI that goes into the internal the internal auditory canal. And that's typically a loop of AICA, and this does not cause pulse synchronous tinnitus. This is a normal finding. There are many, many patients with it who if you get an MRI, you see this. And so don't attribute pulse synchronous tinnitus to this as a cause. I've got a note on the bottom, and I don't want to get too much into this, but there is a syndrome called vestibular paroxysms that's thought to be a vascular cross compression from a blood vessel crossing the root entry zone of the cranial nerve 8, and sometimes that comes with what's called a typewriter tinnitus, which is kind of a staccato, non-pulse synchronous tinnitus. I think it's debatable about whether this condition really exists, and if it does, it is very rare. So I wouldn't routinely use this to diagnose patients. Middle ear tumors like glomus tumors, they can be glomus tympanicum or jugulare. They're vascular tumors, often seen on otoscopy. They often cause conductive hearing loss, so if you're getting audiograms, that might be a clue for it. CT is helpful. MRI is plus minus depending on the location and the size of the tumor. If you find one of these, you want to check to see if it's secreting. The ear tumors don't often secrete, but there is a fairly high rate of genetic mutations that can cause multiple tumors, and so they may have a pheochromocytoma or another tumor somewhere else that could be secreting. So it's an easy thing to check for. Consider genetic testing. I think this is now becoming more and more common with patients who have discovered paragangliomas. And then the treatment can be with surgery and or radiotherapy, depending on the tumor size and location and symptoms. Large mastoid emissary veins can cause a pulse synchronous tinnitus. These are a little tricky because pretty much everybody has these mastoid emissary veins, and for me, it's kind of an eyeball test in that if I'm looking at their CT, if it jumps out at me as like, oh wow, that's a big mastoid emissary vein, then that's something that I may think about. I think that there are some published criteria about what is an abnormally large mastoid emissary vein. I don't know that off the top of my head, and I don't routinely use it, and our radiologists don't routinely use it. If this is the leading candidate for pulse synchronous tinnitus, it can be addressed with ligation of that vein, either through the ear, through an intravascular embolization type procedure. As I was reading about this, preparing for this talk, one of the things that I probably didn't think about as much as I should was if you're going to embark on that route, I think you need to pay some careful attention to their their intracranial venous outflow and what their venous sinuses look like on both sides, because there are reports, or at least there's a theoretical risk, that if a patient is really relying on a large mastoid emissary vein for intracranial drainage and you ligate that, you could cause problems. I haven't seen that, but it is a theoretical risk. And then this is that syndrome that is relatively newly discovered that includes sigmoid sinus wall anomaly, transverse sinus stenosis, and intracranial hypertension. So talking a little bit about what each of these are. So a sigmoid sinus wall anomaly is the term that's been used recently to describe either a dehiscence in the sigmoid sinus wall. So this is the sigmoid sinus here on an axial CT temporal bone. And usually there should be this thin plate of bone overlying it. And in some patients, that bone can be dehiscent, and so the vein is open to the air of the mastoid air cells. And in some patients, it may even go a step further. This is an MRI of a similar axial right ear. And here you can see there's the sigmoid sinus with an outpouching, which is a diverticulum. And there's some pretty good evidence now that this can cause abnormal turbulent flow through the sigmoid sinus, and that flow essentially creates noise that then reflects into the mastoid, bounces around the middle ear, and the patient can hear that. Transverse sinus stenosis, so the transverse sinuses are in the back of the head, and they drain into the sigmoid sinus. And this has also been found to be associated with both of these entities, sigmoid sinus wall anomaly and intracranial hypertension. And basically, that's just a narrowing in the transverse sinus. And intracranial hypertension, I think you're all at least a bit familiar with. And we're going to talk a little bit more about the mechanisms of this and the potential treatment of it at the end of the talk. But I think that this is one of the new areas that's good to be aware of. So after having gone through a list of some of the potential causes, how do we approach these patients when they come into our office? So you start with a history, like you always do, and the questions. Does it sync up with your heartbeat? Which ear do you hear it in? Is it present all the time? Do you hear it right now in clinic? How long has it been there? How bothersome is it to you? And does anything make it better or worse? You know, kind of your standard questions about getting a sense of how severe is this? You know, what is it? Is it actually pulse synchronous tinnitus? Is it something else? And then if you're thinking about the dangerous arterial vascular problems, you want to ask questions like, have you had any cervical trauma or manipulation recently? Thinking about something like a dissection. Do you have a history of hypertension, stroke, or TIA, other sorts of occlusive disease? For intracranial hypertension, you can ask some questions about that. Do they have headaches? Do they have visual field changes? Are they obese? So you can get that from the exam. You can look at their BMI. Superior semicircular canal dehiscence, we talked a bit about the symptoms there, auditory symptoms like can you hear your eyeballs moving? Does your voice sound abnormally loud in your ear? Do loud sounds or straining make you dizzy? And then once you've got an idea of that, you move on to the exam. And there's a few things that are specific for pulse synchronous tinnitus exam that I think are important. One is to auscultate the neck. So I don't routinely carry a stethoscope with me, but I have one buried somewhere in clinic, so I find that, put it around the ear, put it on the neck. Many times you don't hear anything, but sometimes you do. And so, for example, if you hear a bruit in the neck, that's really going to focus your next steps, looking towards carotid disease. And then the other thing that's really helpful with these patients is if they hear the heartbeat in clinic and it's on one side, you can press on their neck. And when you press on your neck, what you're doing is you're occluding their jugular vein. You're not occluding their carotid artery. You have to push really hard for that. And so if you push on their neck and the pulse synchronous tinnitus goes away in the ear, that is a very strong indicator that it's a problem with the venous system. Likewise, if you push on the contralateral side of the neck and it gets louder, that also goes with that because you may be increasing the flow through that venous system and increasing that turbulent noise. You always want to do your otoscopy, your tuning forks, check their blood pressure from the clinic vitals. BMI is useful to think about, or just use your eyeball test for their body habitus. And typically, ear complaints, you're going to get an audiogram. I think it's worthwhile to get it on all of these patients because that's going to point you in the direction of conductive hearing loss or no. Imaging. So this is where I think it can get very confusing. So if there's a conductive hearing loss, I think that a CT temporal bone without contrast is the way to go. That's going to show you a lot of your causes of conductive hearing loss, like superior semicircular canal dehiscence, Tegman defects with encephalocele. Sometimes you can see otosclerosis on there, glomus tumors. So that is what I typically use if there's a conductive hearing loss. If there's not, then it's going to be some combination of the following. So a CT temporal bone with contrast, this will show you all of the stuff that we just talked about, plus it gives you a little bit better look for temporal bone vascular anomalies. Maybe you can see transverse sinus stenosis, might make it a little bit easier to see what's going on with the sigmoid sinus. The contrast, I think, is debatable, but I tend to come down on the side of, in these cases, I get the scan with it. An MRI of the brain and internal auditory canal with and without contrast. This is useful for looking at temporal bone tumors. This is really good for looking at the dural venous sinuses, so this is your best view for transverse sinus stenosis. Sequelae of intracranial hypertension like empty sella, optic nerve enlargement. And then MRA head and MRA neck with contrast. And so this is the scan that's really going to give you a thorough look at the arterial system throughout the head and neck. And this is the best way to look for dural AV fistulas, malformations, aneurysms, cervical carotid disease. And so this is my general framework for this. And I think that you can't really apply like a protocol that you can fit every patient easily into for your imaging for this, but this is what I typically start with. So we talked about if there's a conductive hearing loss, I'll get a CT temporal bone without contrast. If I think it's a venous cause, based on their story, based on neck compression making it go away, then what I'll typically do is I'll get a CT temporal bone without contrast to get a good look at the sigmoid sinus, and then an MRI to look at the dural venous sinuses. And then if I don't get the sense that it's from a conductive hearing loss or a venous cause, then I'm thinking about ruling out those arterial causes as well. And in that case, I'm thinking about getting all three scans. And it's a lot of imaging, and I've spent a fair amount of time talking to our neuroradiologists and being like, is there some way we can do less and actually look for all this stuff? And what they tell me is essentially not very well, in that each of these scans, you're looking for different things on the differential diagnosis. And so you may want to do these in series rather than shotgun ordering all three, especially because you may run into some insurance challenges with that. Or it may be worthwhile, if possible, to just say, they can bundle the MRI and the MRA are essentially do them at the same time without adding a whole lot of time. So let's try to get it all done. So if you find that these patients have sigmoid sinus wall anomaly, transverse sinus stenosis, intracranial hypertension, some confluence of those, the thinking for why this happens is that there's some association between all of it. And it's a little bit unclear what is the cause. It's kind of a chicken and egg thing. So if you think about it from the sense of pulse synchronous tinnitus coming from turbulent venous flow in the temporal bone. So if something causes the transverse sinus to narrow, then the velocity of the flow through there speeds up, and it essentially, that blood sort of flies through there and then gets to the bends in the sigmoid sinus and hits against the wall. And that may cause thinning of that wall over time and the presentation of pulse synchronous tinnitus. Or if there's a narrowing on one side and that causes the resistance on that side to go up and causes more blood to flow down the other side, then that could do the same thing, and that essentially you have more force coming through the blood, and that can also cause these sigmoid sinus wall anomalies. It's a little bit unclear if transverse sinus stenosis results from intracranial hypertension, meaning like the increased intracranial pressure causes the squeeze in that blood vessel, or if the transverse sinus stenosis is something that develops for some other reason, and that increases venous pressure and then feeds into intracranial hypertension. Hopefully in the next few years we'll have that sorted out a bit better, but right now I tend to think of them as sort of an association with an unclear cause. I do tend to think that the sigmoid sinus wall anomalies are secondary to the stuff that's going on higher up in the head. So I wanted to review a couple series about the treatment for these sigmoid sinus wall anomalies, because this falls within our realm. And the best series, in my opinion, was published by Rich Eisenman out of the University of Maryland in 2018. And he looked at a retrospective series of 38 of his patients in 40 ears, where he repaired the sigmoid sinus wall anomaly. And so these panels are from his paper, which shows how he did it. This one shows a diverticulum here. So essentially, he would do a canal wall up mastoid, decompress that area of the sigmoid sinus, reduce the diverticulum with bipolar cautery if there was one, and then essentially resurface it with some combination of autologous tissue like temporalis fascia and bone cement. And he reported that his patients had a 90% complete resolution of symptoms, meaning the pulse synchronous tinnitus went away in 90% of them, and a low rate of complications. There was a systematic review the following year that was published that looked at 121 published cases. And in that series, it found a 75% rate of complete resolution, so not quite as good, but still, pretty good. And about a 15% rate of no resolution or worsening. That paper looked a little more thoroughly at major complications, and it found a 4% rate for that. And those complications usually had to do with the sigmoid sinus, either compression from adding those materials in, or thrombosis. Those patients underwent various treatments for that, and there was no long-term morbidity or mortality. So there is some risk to this, and some of the complications are, fairly scary in that if you get a sigmoid sinus thrombosis in a dominant side, that can cause acute intracranial hypertension and severe issues there. But for the most part, it seems safe and effective. So these are some photos from a case that I did about 6 months ago. This was a young woman who came in with very bothersome pulse synchronous tinnitus in her right ear. Audiogram was normal. Neck compression caused the tinnitus to go away. Got a CT scan and found that there was a large sigmoid sinus wall dehiscence. So this is in surgical position here. It's a right ear, so this is superior. This is anterior. So canal wall up mastoidectomy, and here I think you can tell through these air cells here, you see the sigmoid sinus, which is dehiscent. There's kind of that purplish hue. And so I decompressed that area of the sigmoid sinus, put a temporalis fascia graft on there, and covered it with bone cement. And so conceptually, it's not that challenging of an operation. I think the key to it is that you have to be comfortable dealing with if you get into the sigmoid sinus and get bleeding from there. So I would say if you're not comfortable with that, probably not a good operation to do yourself. But if you do a fair amount of ear surgery and you feel comfortable with that, this is not that challenging. That patient, I should say, I just saw her back this past week. Her pulse synchronous tinnitus completely resolved, and it was gone at her 3-month post-op visit, but now she's complaining of standard tinnitus in the right ear. She's got a normal hearing test, so sometimes you can't win. Transverse sinus stenosis. So if you find that patients have transverse sinus stenosis, that can cause pulse synchronous tinnitus with or without intracranial hypertension. Currently, the thinking with this is that if somebody has transverse sinus stenosis on imaging, the next step is to perform venous manometry, where a catheter is threaded into the transverse sinus and they check the pressure distal and proximal to the stenosis. If there's a significant pressure difference, a stent can be placed. And in the literature, they report that stenting in that condition with intracranial hypertension relieves headache in 80% of patients, pulse synchronous tinnitus in 90% of patients, and papilledema in 93% of patients. Major complication rate, again, 1 to 7%, so it's low, but they're dealing with large blood vessels in the head, so some of the complications can be pretty serious. And one of the issues with this is that it typically requires long-term anticoagulation. So for me, if I see patients with transverse sinus stenosis, I have a neurosurgery colleague who does endovascular work and has an interest in this, and so I send them over to him, and he has this discussion with them. And then finally, idiopathic intracranial hypertension. So this, I think we're all familiar with a bit because it tends to show up in otolaryngology in some different ways. We talked about imaging signs like empty sella, prominent arachnoid granulations, transverse sinus stenosis, optic nerve edema. Symptoms typically are headache, visual field deficits. It's diagnosed with an opening pressure on a lumbar puncture and or a fundal exam looking for papilledema. If they're found to have intracranial hypertension, the initial treatment is weight loss, acetazolamide, CSF diversion like a shunt is sort of the end game for difficult cases. And there's some literature that's been published in our field recently that there's a fairly high association between obstructive sleep apnea and intracranial hypertension. So I would also recommend that if you are finding patients with intracranial hypertension in your clinic for whatever reason, that you strongly consider getting a sleep study on them, or at least asking them about potential OSA symptoms. So in summary, pulse synchronous tinnitus has a large differential diagnosis. I think in my clinic that routine conductive hearing loss is the most common, and that's fairly easy to figure out and take care of. But the most dangerous are these arterial problems that we talked about. Many causes are treatable. Multiple imaging studies are often needed, so don't feel bad if you feel like you're sending the patient back to radiology and ordering every study under the sun for this. As otolaryngologists, we can pay careful attention for third window and sigmoid sinus wall anomalies because those are things that can cause pulse synchronous tinnitus that are really in our realm and we should be experts on finding and potentially treating. And other specialists may not be as aware of these. We talked about this association between sigmoid sinus wall anomalies, transverse sinus stenosis, intracranial hypertension. And this is often a team sport. It often involves multiple specialists, neuroradiologists, neurosurgeons, neurologists. So don't be afraid to get some other folks on board. Thank you very much. Interesting. So you found it on traditional interventional cerebral angiography. Yeah, I have to say that I don't know the sensitivity that well for MRA for picking up those types of lesions like AV fistulas or malformations. But in my discussions with our neuroradiologist, that was their recommendation. You know, interventional cerebral angiography has some risks to it, and it's a tough step to send patients for. But I think it's a good point. And my take from that too is that this is something where a neurointerventionalist would probably be helpful as well. So if you have a suspicion for that, getting the patient over to somebody there who has more knowledge about the relative trade-offs of those different modalities would be good. Yes? Do I repair them? I do, but what I tell patients is that it's not a dangerous condition. So it's really driven by how bothered they are by their symptoms. It's something I have an interest in. I think I could do it fairly well and with fairly low risk. And so for patients who are sufficiently bothered, and we go through the risks of changes to their vestibular system afterwards and risk of hearing loss, which is, I quote somewhere probably between like 5%. Some of the literature says 20%, but I think that that's probably quite high. If they understand the risks and are sufficiently bothered and want to do the surgery, then I've seen it help a lot of patients. All right, great. So next up, we have Dr. Jeff Sharon, who is an assistant professor at the University of California, San Francisco in the Department of Otolaryngology. He is director of the Balance and Falls and Vestibular Center at UCSF. And he started there my chief year when I was in residency. And so we got to work together a bit there. And it's been really enjoyable following him over these past few years. He's done a lot of great work in vestibular disorders and vestibular migraine. And so he's going to give his first talk this morning on vestibular migraine, which I'm so happy about because I think that this is one of the most under-recognized things that we see in all sorts of otolaryngology complaints. So Jeff, thank you very much for joining us. And you got the HDMI that goes into there.
Perfect.
Yeah.
Let's see. Okay. I think we're good.
All right. Thanks, Jeff.
All right. Well, thank you, Nick. That was a fantastic talk, an overview of a tricky subject that I think we all struggle with. Everyone could hear me okay? All right. Well, it's a pleasure to be with you this morning. I'm giving 2 talks, so one this morning on a passion of mine, vestibular migraine. It's a deep look at everything and a bit of my own interests and research and things like that. And then tomorrow's a fun talk that's a overview of the vestibular system and a general approach to dizzy patients. So we have updates, evidence, and challenges. My email address is on the last slide, and I'm happy to send out the slides to anyone who wants it. So if you'd like it, just shoot me an email, and I'll share it with you. And I'm also happy to correspond or answer any questions by email as well. So if you want to take notes, feel free. And if you want to just sit back and relax, I will send you the slides. I do have some disclosures. The most relevant one is at the end, I'll talk about a randomized clinical trial that we're doing for vestibular migraine. It's funded by Eli Lilly because it's a drug that they make, galcanezumab or Emgality. So one of those CGRP blocking medications that's all the rage in migraine these days. So I get research support from them. The other disclosures are not relevant. I was once told you should throw a meme into every talk you do, so there's my meme. So why should you care about vestibular migraine? So here's my reasons. Number one is it's extraordinarily common, shockingly common. Your patients have vestibular migraine. It's impossible for them not to. If you're in an elevator, probably someone has vestibular migraine. It is not possible to care for patients with audiovestibular complaints without understanding migraine, and I'll spend the first couple slides trying to make a case for that. And it's a treatable condition, and patients do get better with treatment, so I think it's worth thinking about from that perspective. So before we dive into that, I want to share a couple thoughts on migraine in general. Migraine is it's phenomenally common. It is shockingly common. It's so common to the point where you wonder, how is a medical condition this common? Like, is there some adaptive advantage, or are our brains just not designed for modern life or something like that? Because it affects about 10 to 15% of all people worldwide. 1 to 4% of the population is chronic migraine. These are patients who you ask, how long has your migraine headache been lasting? And they tell you, oh, since 2010 or so. Migraine is the 6th highest cause of disability worldwide, but when you consider people in their working years, it's the highest cause of disability in the world. That's important because people tend to underestimate migraine. It's a migraine, you should get over it, just take an Advil and get back to work. But it's the highest cause of disability for people within their working years. We think of migraine as a headache disorder, right? That's what we're taught. That's what the neurologists would have us believe. But the earliest manifestation of migraine is not headache, it's vertigo. We now recognize that benign vertigo of childhood is a migraine precursor. So we have kids, as early as 2, 4 years old, 6-year-old kids complaining of dizziness. Later on in life, they go on to develop migraine headaches. For years, it was a mystery. Why are these kids complaining of vertigo? There is a powerful connection between migraine and vertigo, where migraine causes people to feel vertiginous. I don't think these kids are making things up. I don't think they're capable of that. I think there's a powerful biology at play here, and seeing it in such young kids just underscores that. We don't fully understand why. So there's a complicated animation showing vertigo in a baby. I'm a PowerPoint master, what can I say? Here are some things to consider. And I think when you really think about it, it's pretty shocking, right? So when you learn about different disorders, vestibular disorders, they're all presented as separate, right? But they're not. More than half of patients with Meniere's disease meet criteria, International Society, International Headache Society, or International Classification of Headache Disorders criteria for migraine. Half of them, right? So we saw that migraine affects 10% of all people, but with Meniere's disease, it's half. Way more than you'd expect by chance, right? So there is some fundamental connection between Meniere's and migraine. That can't be a coincidence. Migraine is associated with a 2-fold increased risk of BPPV, and I'll share some of my own data on the connection there. 50% of patients with idiopathic bilateral vestibular loss have a history of migraine. How is that possible? Right? So this is a large series from, there's different efforts around the world now to develop a vestibular prosthesis, and there's one at the University of Maastricht and Zurich. So they have a large series of patients with bilateral vestibular loss, and they found that half of them, where they couldn't find a genetic cause or an autoimmune cause or canvas or any other of a number of named disorders, have a history of migraine, right? Is it really the case that migraine doesn't damage the audiovestibular periphery like we're all taught? Or is it the case that migraine works in mysterious ways and we're calling it something else once it starts causing damage? So a couple of years ago, we tried to look at the landscape of vestibular diagnostics and realized that these diseases aren't separate, right? When you start looking at them, a lot of them are related to each other. So we tried to draw out what we thought the different vestibular diagnoses look like. And what we came up with is a lot of overlap, a Venn diagram with a lot of overlap. But you can see at the center there is vestibular migraine, which overlaps with a lot of different conditions. Then there's questions of disease modifiers, like anxiety, head trauma, and aging, someone's balance, and then things that seem to cause chronification of symptomatology and maladaptation, and that's where you get into things like 3PD, persistent postural perceptual dizziness. It's not as simple as you would think, and in the vestibular space, it's not weird or unusual to give someone two diagnoses. It's different than other types of medicine where, once you know it's a squamous cell carcinoma, it's probably not a Warthin's tumor or something like that. So we looked at our own data for BPPV and migraine. So we took everyone who had a nystagmus confirmed diagnosis of BPPV at the Balance and Fall Center, and we just divided them up. Did they have a history of migraine or not? And when you do, you find something interesting. Those with a history of migraine presented earlier in life than those without. And that was a highly statistically significant result. So our conclusion was that migraine causes BPPV earlier in life. That's been my clinical experience also. If I have someone who comes in with bad BPPV and they're in their 30s, I'll put money down that they have a history of migraine. I think it irritates the otoconia enough in unknown ways that it causes an earlier manifestation. What about migraine and other otologic symptoms? Well, migraine, again, is behind the scenes, this emperor behind the curtains pulling all the strings, right? So tinnitus, 3 times more common than migraine. Hyperacusis, well, in the migraine literature, they just call that phonophobia, and it's a cardinal feature of migraine, but it's the same thing. Migraine is a risk factor for sudden sensory neural hearing loss, and oral fullness and otalgia are both common migraine symptoms, and I'll show you some of my own data on that. So there's emerging recognition that you can have isolated oral fullness as a migraine manifestation, and if you treat it, Hamid Jalilian has some data that if you treat isolated oral fullness with migraine medicines, it'll resolve a significant percentage of the time. So basically, migraine seems to be the secret force that's behind almost every symptom or disease state that I see or treat. That's my conclusion over the last 5 years. So let's dive into vestibular migraine. So it is accepted as a distinct disease that causes dizziness, whether it's separate or subtype of migraine headaches, I think is more an issue of nomenclature. There's a German study that estimated the prevalence at 1% of the adult population. I will share with you some US-based data. It's debatable if it's the most common or second most common cause of dizziness out there. Diagnostic criteria were originally proposed by Neuhauser in 2001, and then they've basically been incorporated into the Baronese Society criteria. The Baronese Society is wonderful. It's an international group of vestibular researchers, and they come up with diagnostic criteria for different vestibular disorders, and they're all on their website. They publish in the Journal of Vestibular Research, JVR. So if you ever want to know what's the formal criteria for diagnosing superior canal dehiscence or 3PD or Meniere's disease or vestibular migraine, you can just use the Baronese Society criteria. And for the most part, they're very reasonable. I am going to poke some holes in their diagnosis for vestibular migraine later on in the talk, but for the most part, it's a great starting point. So 2001, right? We tend to think of superior canal dehiscence as kind of the newest and latest discovery of a disease within the neurotology space, because that seminal article was published by Lloyd Minor in 1998, but actually widespread recognition of vestibular migraines about the same time frame. So they're both kind of the newer disorders that we now recognize. But is there anything new about them? Probably not. So look at this description by Arteas of Cappadocia over 2,000 years ago, where he ties together headache, tinnitus, and vertigo. So it's the three of the cardinal features of vestibular migraine. If darkness possesses the eyes, the head be whirled round with dizziness, and the ears ring. And the descriptions of tinnitus are kind of interesting because they're like the everyday scenes of his time period. So the sound of rivers rolling along with great noise, or like the wind when it roars among the sails, the clang of pipes or reeds, or the rattling of the carriage. We call the affection vertigo, a bad complaint if a symptom of the head, but bad likewise if a sequela of cephalea, of headache. So it was recognized even back then that the two are connected, vertigo and headache. So this is the consensus criteria per the Baronnet Society. Now, it's worth knowing that the neurologists tend to use the International Classification of Headache Disorders, ICHD, which relegates vestibular migraine to the appendix. I learned from neurologists that the appendix is for diseases they don't truly believe in, so it's kind of like the wastebasket at the end of the diagnostic criteria, and they don't include the probable vestibular migraine category. But I think the Baronnet Society is closer to the truth here. So you can have either vestibular migraine or probable vestibular migraine. Vestibular migraine is when you have 5 episodes lasting 5 minutes to 72 hours. So I'll present some research in a bit that argues that maybe that restriction on time course doesn't make a ton of sense. Then you have a current or prior diagnosis of migraine with or without aura per the ICHD criteria. The ICHD, by the way, are on a website run by the International Headache Society, so you don't have to memorize them. You could just Google them when you're in clinic, and you could read them out loud, so it's a nice resource. And they have criteria for diagnosis for all different headache disorders, so it's worth being aware of. And then you have the vestibular episodes with classic migrainous symptoms, so photophobia and phonophobia, or migraine headaches. And probable vestibular migraines, one or the other. So you either have the vestibular episodes with those migrainous symptoms, or you have a prior history of migraine with or without aura, plus vertiginous episodes without the symptoms. And in my clinic, it's probably split 50-50 between the vestibular migraine and the probable vestibular migraine. Well, what else should you consider when you see someone with episodic vertigo? You know, the big three are vestibular migraine, BPPV, and Meniere's disease, but there's a lot of other things to just keep in the back of your head. You know, superior canal dehiscence, vestibular paroxysmia, which I think I believe in more than Nick does, it sounds like, vestibular schwannoma, and other things. So, what does my clinic look like? So here's a UCSF cohort from a number of years ago, and you could see that combined together, definite and probable vestibular migraine accounts for about half of all the patients I see. Now, you can't take these things in isolation. I also have a research interest in this condition, so I get more referrals for that, but it is very, very common. For me, it's far more numerous than Meniere's, than BPPV, than unilateral or bilateral vestibular loss, or some of the other causes. What's interesting, and probably just something we have to accept about this condition, is that comorbid depression and anxiety is a very high incidence. And this is kind of the elephant in the room, because we all know that these patients can be tough to take care of. And we just have to accept that this is a reality of this disease state, that it has a very high incidence of depression and anxiety. There probably are neuroanatomic reasons for that. There's strong vestibular connections to some of the dopaminergic and serotonergic centers within the brain. So there probably is a real basis for that, but it is something to acknowledge. Take a moment to yourself before you go into those exam rooms, and if at all possible, budget a little extra time, because we all know, especially the patient counseling with someone with anxiety can take longer because their brains have trouble accepting the information that you're trying to provide, no matter how good you think you are at explaining stuff. Okay, so I made a list of questions when I started at UCSF, so the rest of the talk is my attempts to answer this list of questions. They were just all very basic questions. I feel that vestibular migraine is an understudied condition given how prevalent it is, so there was a lot of low-hanging fruit to go after in terms of learning more about this disease. Okay, so question number one, what is the prevalence in the US? So to get at that, one of my former residents, Eric Formeister, used some NHIS, National Health Interview Survey data, which is a large nationally representative database that covers about 22,000 people. We generated a case definition for vestibular migraine, which we later validated in our clinic by giving patients those same questions and realizing it correlated really well with a diagnosis of vestibular migraine. And the results were that vestibular migraine probably affects about 3% or so of the US population. That makes sense to me, right? Because if migraine's 10%, it's a subset of that doesn't perfectly overlap, but that number resonates. It's a full spectrum of disease, right? So even though it affects that many people, some people are on disability from vestibular migraine, and some people have mild symptoms and they've never seen a doctor for it. So it's the full spectrum. 60% in that cohort miss school or work because of vestibular migraine, and a half see a doctor. So you're getting some people who don't see physicians about it as well. It is a risk factor for falls, so much higher rate of falls in those meeting the case definition. Most people aren't told that vestibular migraine is the cause for their symptoms, so there's a significant problem with underdiagnosis. The statistical connection between migraine headaches and dizziness is incredibly high. So your odds ratio of having a dizziness problem if you have a migraine headache problem is some of the lowest p-values you can find in a research study. Most of the people in the cohort are told that the cause of dizziness is other health problems, which probably underscores the fact that a lot of people are, even if they see a physician, they're confused about what they were told and what their diagnosis is in regards to their dizziness. Similar to migraine headaches, most people with vestibular migraine are female. Okay. So then another one that I was interested in early on is, I was seeing these patients, I was diagnosing them, and they'd say, no, I don't think you're right, doc. I know what my migraine headaches feel like, and this is very different. I don't think this is related to migraine at all. So we tried to look at what are some patient attitudes towards vestibular migraine. So we ended up giving surveys to about 70 patients coming in to try to figure out what were they thinking. There's a couple myths about migraine that I think underscore some of the problems we have with communication. One of them is that a migraine equals headache. Migraine has to cause headache. Well, we all know that's not true, right? You can have migraine auras without ever having a headache. Actually, I'll share with you, that's what I get. I get migraine auras sometimes, and I've never had a migraine headache. And actually, they only started after I started researching vestibular migraine, so there's irony for you. People think that migraines have to be episodic. They can't be continuous. Well, chronic migraine is when you have 15 or more migraine days per month. Status migrainosus is a migraine that lasts longer than 72 hours. The headache literature perfectly understands that there's a chronification that can occur with migraine symptoms. So we need to understand that that can occur with vestibular migraine as well. I think this is more of a heuristic thing. People, the more providers you see, the less likely you are to think that you're going to get a diagnosis, but also the more likely you are to think that you have some rare exotic thing. I have a lot of patients who come in who kind of want to have superior canal dehiscence. They think that is rare. That's why no other doctor told them that this was the cause of their symptoms. It has a dramatic surgical fix, which will provide validation in their lives to everyone that they've been telling that they have a real problem. Well, now they need brain surgery. That was a real problem. But the truth is, vestibular migraine is far more common and far more underdiagnosed. They're just more likely to have that. People think that migraine, no, this is too severe for migraines. I can't work, I can't drive, I can't do all this stuff. Migraines is something my mom had, but she would just get over it. She would just work through it. She'd take 2 Advil and keep going. So this can't be migraines. All of those things are false. The patient attitude survey was actually a little bit sobering, a little disappointing. So a plurality of subjects were neutral in terms of whether or not they thought we'd figure out what was going on with them. There also a plurality was neutral as to whether or not treatment would help them. And many people who, even those who meet criteria for migraine, don't believe migraine causes dizziness. So I think we have a patient education issue on our hands. Okay, so how do we measure disease severity? So this was kind of a foundational problem for me. I wanted to study vestibular migraine, but to study something, you need a way to put a number on it, and we have a disease that doesn't cause any characteristic pattern of abnormalities on audiovestibular testing. So there's nothing on MRI, there's nothing on labs, there's nothing on vestibular testing, there's nothing on audiometry. So how do we put a number on someone suffering and see whether or not our treatments work? Well, the simplest thing is patient-reported outcome measures, and the widely used patient-reported outcome measures for all things dizziness is the Dizziness Handicap Inventory. But the Dizziness Handicap Inventory is a symptom-specific outcome measure. It measures disability related to dizziness. And with vestibular migraine, you have a whole plethora of symptoms. So you can have headaches, you could have light sensitivity, you could have sound sensitivity, you could have ear pressure. We needed a way to incorporate all of that symptomatology into a single score to be able to measure and track disease-specific disability. So because of that, we decided the easiest thing would be to develop a patient-reported outcome measure for vestibular migraine. So we named it Vempathy because it sounded like empathy, and that sounded neat to us. It's the Vestibular Migraine Patient Assessment Tool and Handicap Inventory. We met with some statisticians and did a kind of middle-of-the-road approach, so not the fanciest way to develop one of these outcome measures and not the worst way either. So we did a lit review, we did expert panels, multidisciplinary panels, and patient feedback to develop an initial item bank. And then we used that item bank and administered it to 50 confirmed vestibular migraine subjects, 18 control subjects to look at discriminant validity, and we administered it at 3 time points. Initially, a week later to assess test-retest reliability, meaning you don't want to have an outcome measure that every time you take it, your scores are wildly different. That's not valid. But you also want one that changes and correlates with positive treatment. So if people say they're getting better with treatment, you want scores on your outcome measures to drop. That's called responsiveness. So we wanted all these nice characteristics. Vempathy ended up being a 25-item questionnaire. It's freely available on our UCSF Balance and Fall Center website, and there's a link to that there and also at the end of the talk. And it actually was responsive, so you can use it to track progress over time. The statistical performance of it was very reasonable. It worked well. So Cronbach's alpha, higher scores closer to 1 are better. That's a measure of validity. And internal reliability was high. Test-retest was excellent. The discriminant validity was good, so people with vestibular migraine scored high. People without vestibular migraine mostly scored 0 to 10 on this scale, so not high. And the scores changed with treatment, and we've later confirmed that, and I'll show you some data about that. And it correlated well with quality of life measures. So, we used some general quality of life scales, and there was good correlation. And it actually correlated reasonably with the dizziness handicap inventory. That's a good thing, because they're measuring similar constructs, but it didn't correlate perfectly, which was also good in our mind, because if it did, then we probably had wasted a bunch of time and we should have just used the DHI. So they measure slightly different things. So I'll show you a scatter plot. They correlate pretty well. Here's a histogram showing what approximates a bell-shaped distribution of empathy scores. That's good. You don't want to have any sort of odd distribution if you have a patient-reported outcome measure. This is what you statistically would expect. Here is box and whisker plots showing scores of those with vestibular migraine, and you could see they cover most of the scale, right? They're going all the way up to 100 to all the way down. Usually they're not scoring that low because they're seeing me, they have some disease-related disability, but then control subjects are very low. It's very rare to find someone who had a significant score above a 10 even. Here's the scatter plot of DHI versus empathy, and you could see it's pretty well correlated, right? It kind of that nice ellipse or football shape, but it's not exactly the same thing. There is some variation in the data. It's not a single line. So this part was very interesting to me, and I learned a lot from it. So once you develop one of these patient-reported outcome measures, you can do some statistical fun, exploratory factor analysis to discover latent clustering within the different questions, which are called items. So you could see, do some of the things that you're asking about statistically cluster together, and does that give you a clue about which things are more similar than not within all the vestibular migraine symptoms? And so we found 6 different clusterings. And then they seem to be organized pretty well thematically. The themes we applied, but the clusterings, we didn't decide these things were clustered together. The statistics just tells you they're clustered together. Some of the things that I learned that was interesting. So number one, I've always scratched my head when someone comes in and says they're lightheaded. And I'm like, is that dizziness? Is that a feeling of pre-syncope? Like, what exactly is someone experiencing when they say they're lightheaded? In our data, it actually correlates really high with stress and anxiety symptoms. So now I think I view lightheadedness as more of a symptom of stress or anxiety in most patients. Motion sickness, nausea, spinning, they kind of all cluster together. That makes sense. There's motion sensitivity. Another interesting thing was that ear pressure, head pressure, which is common in this population. Some don't get headaches, they get a head pressure, and headaches all cluster together. So I now view ear pressure in this population as like an ear headache because of this clustering. And then there were some other themes of senses of being overwhelmed, central audiovestibular disturbances, and issues with cognition, which itself is a whole interesting discussion that we probably won't have complete time for today. Okay, so moving along, what about impacts of quality of life? A lot of times we hear from patients that vestibular migraine is affecting them a lot, and it drives them nuts because they don't have anything to show for it, right? They look normal, so people assume they should be acting normal. It's kind of like a silent disease, and they keep hoping that their MRI is going to show something, so they have some validation that they could show to their friends and family and say, here, the doctor did find a problem. This is why I've been having so much issues. And they get so disappointed when all their testing comes back normal. So there are pretty stark effects on their quality of life. So this is the SF-36 scores. This is a commonly used quality of life metric, which is 8 different domains of functioning. Things like physical functioning, body, pain, energy, mental health. And you could see there that higher empathy scores for most of these metrics correlates pretty well with worse functioning and worse scores on the SF-36. What's interesting is, for comparison purposes, I pulled up average, or not average, but reported SF-36 scores in these 8 domains for patients with what I think of as a very severe condition, bilateral vestibular loss. And then there's normative data available for a healthy US population. And then I compared it to the scores we got for our vestibular migraine population. Now, higher scores are better. So 100's perfect health. You can see the healthy US population does not score 100 across the board. That's no surprise to any physician out there. What was interesting to me was that sometimes vestibular migraine patients were performing a lot worse than bilateral loss patients in terms of their self-reported disability. So like role limits physical, I would have thought the bilateral loss patients would have done a lot worse, but it's actually vestibular migraine by a large margin. More emotional effects, social issues being affected more, energy being affected a lot more. This is just to say there is some validity to the complaints that we hear in the patients about how severe this disease can be. It's the full spectrum, as we saw before. Okay, what are some secondary impacts of vestibular migraine? So missing work, risk of falls, cognition. So we took some looks at that as well. So here is a study I did with a colleague, Habib Rizik at MUSC, and we gave subjects the Cognitive Failures Questionnaire. So it's a questionnaire that looks at everyday cognitive slips. Did you forget where you put your keys? Did you forget someone's name? Did you forget what you went to the store to go buy? It will not surprise you that normal human beings don't do great on this test. Turns out we all have terrible memories and terrible attention and concentration. So the normative scores are actually closer to 30. A perfect score would be a 0. But what you could see is those with 3PD, persistent postural perceptual dizziness, VMMD was vestibular migraine and Meniere's disease, the two of them together, and those with vestibular migraine all score significantly higher than control subjects. There are strong connections, neuroanatomic connections between the vestibular periphery and some of the cognitive areas of the brain, right? There are very interesting experiments where you can take a rat, remove their vestibular system, and put them in a maze. And what's interesting is it's not that they stumble around and can't get around. They can't spatially navigate anymore. They can't find where home is. If they are given some food, they can't navigate back to where they're supposed to go. They can't form a mental map of the world around them anymore. And there's some suggestions that our ability to form mental maps of the world around us is one of the features that underlies abstract thought, right? We tend to think of things as like ideas as closely related or far apart, things like that. We probably use some of the same neural architecture for navigation as we do for thinking. So it's probably not a coincidence that a lot of vestibular migraine patients have this brain fog, penumbra, that affects them and that they complain of. So we looked at this with some more recent NHIS data. So again, large nationally representative database, which is nice, self-reported data, which is less nice, and we tried to see what are the correlations with cognitive dysfunction and vestibular migraine. So we, again, use the validated case definition for vestibular migraine. When you look at self-reported cognitive dysfunction, so some difficulty thinking or remembering or a lot of difficulty thinking or remembering, the rates are far, far higher than control subjects when you have vestibular migraine. Almost 50% either have some difficulty or a lot of difficulty thinking or remembering, compared to just 12, 13% of controlled population. Even those with migraine headaches don't do as badly as those with vestibular migraine. Falls and mobility are also affected. So you have far higher odds of having falls over the last year, self-reported falls, or difficulty with mobility, meaning difficulty walking 100 yards on level ground if you have the vestibular migraine condition. You're also far more likely to miss work days. And there's additive effects here. If you have vestibular migraine and cognitive dysfunction, you're even more likely to have the falls, the trouble with mobility, and the missed work days. And that makes sense, right? We know it's related to a condition that's the highest cause of disability amongst working age adults. All right, so let's go down another tangent. Are current diagnostic criteria adequate? So I've been hinting at this, right? Current criteria want each episode to last 5 minutes to 72 hours. But we all know that migraine headaches are allowed to last however long they last. The criteria don't impose a strict limit on them. We just take our patient's word when they tell us how long their symptoms last for. So we conducted a prospective study of vestibular migraine phenotypes. So we prospectively enrolled 54 subjects who met Baronese Society criteria for vestibular migraine, except we didn't use time course to exclude anyone. So you could have episodes shorter than 5 minutes, longer than 72 hours. You met all the other criteria. And then we asked about a number of different features of their migraines. What we found was that in this patient population, a prior migraine history is very high, as you'd expect, but some people don't have that because they are in that probable vestibular migraine diagnostic category. Family history of migraines, about 50%. That makes sense. But 44% of subjects report that their vestibular symptoms are continuous, not episodic. So I think that's a big deal. I think the current diagnostic criteria envision vestibular migraine as an episodic condition, and it's probably not. It probably, just like migraine headaches, has episodic and chronic variants. Anyone who sees a lot of these patients, this makes a lot of sense to them. Motion sickness, well, we all kind of know this. History of motion sickness is very high in this patient population at 60%. So here you go, right? If you divide people up by their most common dizziness duration, it's almost 38% who have longer than 72 hours at a time when they have dizziness. Or when it comes on, it's for a couple weeks, things like that. What about their dizziness frequency per month? A lot of these patients have a pretty high symptom burden, and just based on having more than 15 days per month would be classified as chronic, not episodic. So 60% have more than 15 days per month. This one I found interesting. We gave everyone a long list of all potential triggers for their episodes. And this one's a huge diagnostic clue when you're trying to figure out, does someone have vestibular migraine or not? So here's the list of vestibular migraine triggers in descending order. So motion, head motion, body motion is a very common trigger. Stress is a very common trigger, and I'll talk a bit more about that in a minute. Bright lights, busy visual scenes, scrolling on a screen, sleep disturbance, loud noises, dehydration, barometric pressure changes. We've all heard this, right? These are common complaints that people come in with, and it's because they're all common migraine and vestibular migraine triggers. Associated symptoms during dizziness, the main thing to point out here is I think head pressure is common in this population. Not everyone has a migraine headache. Oftentimes they've had migraine headaches, and then when they're with their vestibular migraine episodes, they get head pressure instead. Ear pressure also tracks with head pressure. So We propose that, similar to headache, we should divide vestibular migraine into episodic and chronic forms and have diagnostic criteria for each. All right, we're getting through it. Just 3 more questions left. So are there effective non-pharmacologic treatment options? Why is that important? Well, this patient population has a sensory hypersensitivity problem, right? Lights are too bright, sounds are too loud, touch is too much, smells are too strong. You know what else is part of that? Medications are too much also. So they will tell you, I don't do good with medications, right? And a lot of them are trying to have their symptoms treated without using medications. So there are some strategies to try to help with that. So one of them is a trigger avoidance, right? If we know all the triggers, we can advise patients on how to avoid them, right? Reduce stress, sleep optimization, regular schedule, treat anxiety. I generally view it as much better to see anxiety, to conceptualize anxiety as a comorbid condition and not blame the anxiety for their symptoms, because otherwise you'll just lose your patients, probably in 2 ways. Because they will just think that you're not taking them seriously. You're just chalking it all up to the anxiety. You don't want to do that. You want to say this is an important part. We have to acknowledge it and treat it because we get better outcomes, but it's not the ultimate cause. It's a related disease. Dietary supplements have been well studied in migraine headaches, not studied for vestibular migraine, but they are pretty favorable side effect profiles, so it's reasonable to suggest them, and they are available online in like combination pills like Migravent or Migraleaf, things like that. I realize this slide is too small to actually see, so I apologize for that. This is more for, it's my treatment algorithm, all in one slide, but if anyone emails me and gets the slides, then you'll have the whole treatment algorithm, or if you have really good smartphone cameras, feel free to go for it. After the diagnosis, it's a stepwise approach like any condition, right? Try to do some conservative treatments. If that doesn't work, then oral prophylactics. And if that doesn't work, then I'll talk about some of the newer approaches with CGRP blockers and things like that. At the same time, we try to have a plan for symptoms and symptomatic medication as well. Okay, so we saw a couple things, right? We saw that stress was a #1 trigger. We saw there's very high rates of anxiety. And I live in San Francisco also. So we had to do a study on mindfulness-based stress reduction for vestibular migraine. So this was in partnership with a UCSF center called the Osher Center for Integrative Medicine. And the thought was maybe this would be a helpful non-pharmacologic treatment for vestibular migraine. So it was a prospective study of 20 subjects. We thought that this condition might be well suited towards a mindfulness approach because of all the functional maladaptations, catastrophizing behaviors and thoughts, hypervigilance, which can make symptoms more chronic. So we enrolled all these subjects at a 8-week, and it was intended to be an in-person sessions at the Osher Center. It ended up actually all being over Zoom. So it was kind of shocking to me that it even worked, as we'll see, because it wasn't an in-person mindfulness intervention. It was a Zoom-based mindfulness intervention because of COVID. And I don't find Zoom particularly relaxing or de-stressing, but I will show you the data that we had. All subjects had to read Full Catastrophe Living, which is kind of like the Bible of modern medical mindfulness by John Kabat-Zinn. And it focuses on attention, attitude, there's breathing, there's some yoga, and one of the main tenets is to experience the world in a non-judgmental fashion, right? So almost to take a step back from your symptoms. So when you experience vertigo, to acknowledge it and to take a step back and think to yourself, oh, I'm experiencing vertigo right now, but to build almost like a mental barrier so that you're not wrapped up into it, but that you can kind of view it dispassionately and somewhat separately. So it was funded by a core grant through the Association for Migraine Disorders. And here is our data. There's the demographic stuff, kind of the usual what I've been showing you, so I'll skip over that. What we found was that dizziness handicap inventory scores, and by the way, just a single arm study, we couldn't work out a control group, so a limitation, dropped significantly before and after intervention, but you could see not down to 0, just a significant drop, right? This isn't a cure. Vempathy scores also a significant drop, but not down to 0. So symptoms were dropping, but they weren't going away. We gave patients PHQ-9, that's a depression inventory. We saw there's high rates of depression in this population. Well, you'd expect this to drop. Mindfulness has been well studied for depression, and it did drop. And we gave subjects GAD-7. That's a well-studied anxiety index, and that also dropped, so significant benefits there. We also gave them that CFQ, the Cognitive Failures Questionnaire, which I mentioned before, because we're curious, do some of this brain fog stuff get better with treatment? Or is it just there and it's part of the disease? And interestingly enough, scores did drop a bit. And then PROMIS, which is a quality of life score, also improved. So we were sending patients text messages every day during the study, rate your dizziness, none, mild, moderate, or severe. And what we found is that when we started MBSR, their average score dropped. So they, if you code the severe as a 3, moderate as a 2, mild as a 1, their average score over that time period does fall. What became very interesting, though, is when you start looking in detail at the data in terms of what was going on with each day. Because you would think, oh, they drop because all 3 of them are getting less frequent over time. That's not what we saw at all. What we saw is that the mild days went up and the moderate days went down. And the 2 curves are basically mirror images of each other. Look at the orange and the gray there. So probably what's happening is the mindfulness gave people a toolbox that let them experience their moderate days in a different way. And to them, it became a mild dizzy day rather than a moderate dizzy day. So that's what I think the benefits of the intervention are. It's not a miraculous cure, but it can be a helpful adjunct. Okay, are there effective medications? So we use a lot of the regular migraine oral prophylactics, right? Nortriptyline, Topamax, Verapamil, and Propranolol, with the idea that, well, if there's good evidence they help with migraine headaches, maybe they're helpful for vestibular migraine. And here is a detailed slide with a lot of dosages, precautions, side effects, and some benefits. Sometimes you try to treat 2 birds with 1 stone. Or I saw recently we're supposed to say now you can feed 2 birds with 1 scone. That's the language we're using in San Francisco. It's all there for you. I think based on time, I'm going to have this as a reference, and if you want this as part of the whole presentation, just send me an email and you'll have it as a reference. I use all these medications, and the truth is sometimes they work, sometimes they don't. There was very recently a randomized clinical trial in Germany looking at metoprolol versus a placebo for vestibular migraine. They had a planned enrollment size that was quite large, of 266 patients. They stopped the trial after 6 years because they didn't get to their enrollment goal. But they still had 114 randomized subjects who they analyzed and did not see a difference in any of the clinical outcomes. I would argue that if you have that many patients and you don't see a difference, it's probably too small of a difference, if it is a real one, to be clinically meaningful. So based on this, I've stopped using beta blockers out of all the things I showed you in the prior slide. So is treatment effective? Well, we don't really know. There are no good randomized clinical trials out there other than that Promovic study that have a placebo arm, have blinding, and have a treatment arm that help answer that question. So what we've been doing, and I mentioned this at the beginning, is a funded trial called the investment trial, or Investigating Vestibular Migraine and Emgality Treatment. It's a double-blinded, placebo-controlled, randomized clinical trial funded by Eli Lilly, and we're currently recruiting. We're about 80% of the way through, so hopefully we'll have some results by the end of the year if things go well. So why CGRP? Why try to use a drug that treats CGRP, calcitonin gene-related peptide? Well, we know now that there's numerous studies that have shown that this new class of migraine medicine works well for headaches. And a lot of patients have described it as a game changer. And there's injectable monoclonal antibodies, right? Aimovig, Agivy, Emgality. And then there's these newer ones that you see all the time advertised for, right? The oral CGRP blockers, the small molecules like Nurtec, Ubrelvy, Qulipta. So they're an important class of medication. We need to know, do they work for vestibular migraine? Anecdotally, they do seem to work, and there have been some early studies, including a early Arizona-based study from Terry Fife showing some efficacy in vestibular migraine, but that's not a randomized study. Now, CGRP, though, is expressed in the vestibular periphery. So it's not a randomized target. There's a researcher, Ann Lubke, at University of Rochester, who has shown this. And she's grown CGRP knockout mice, and they do have VOR abnormalities and impaired balance. So CGRP probably does play a role in the vestibular system. And there you could see some staining for CGRP within mice utricles. So the study is basically, it's pretty simple. It's 3 months of treatment, 1 month baseline, daily text message to keep track, and then questionnaires at each time point, and it's a one-to-one allocation. And I am running low on time, so I'm just going to skip these slides. They're all available on clinicaltrials.gov if you're interested more in the study design. But basically, patients with vestibular migraine is the main inclusion criteria. So this is what the text message system looks like. It's pretty cool, actually, and the rates of people responding to a text message is very high, like 97%, so it's way better than doing the old way, which is a paper diary of symptoms, which response rates are usually 50%. So the text message, I think, is the way to do clinical trials going forward. You get a lot of good data. Okay. Pathophysiology. Well, this section short, we don't know. I was writing a textbook chapter, and we collaborated with an artist out of Stanford, Christine Graylap, to create this neat illustration of all the potential areas where vestibular migraine might be causing symptoms. And it's anywhere from the labyrinth up to some of the cortical areas that do multisensory processing. But the truth is we need to know. So this is another study that we just started scanning patients, where we're going to do an fMRI study of subjects, and it's a cruel study. So we're basically showing them videos to provoke vertigo while they're in the scanner, and we'll look at which brain regions light up and compare them to control subjects and also subjects with migraine headaches, which I think will be very interesting, right? What are the differences in neuroanatomy and functional neuroanatomy during vertigo episodes when you have just headaches versus when you have vestibular migraine? So here's my list of clinical pearls. I'm going to skip it just to have a little time for questions. And here's my summary slide. Vestibular migraine is incredibly common, and it is treatable, and more data is coming. And this is my thank you slide to all my wonderful students and collaborators, and also to the people who funded some of the data I've shown you. And I like to draw in my free time, so here's my temporal bone. And there's our website, which has some of the resources I told you about, and my email address, so I welcome any emails or questions or anything else. Thank you. Two seconds left. All right, yes. Yes, I didn't get into that. I do. When I was training, we were very big on making them strictly follow a migraine diet, right? And there is this available online, like Hopkins Vestibular Migraine handout. If you Google like Hopkins Vestibular Migraine, it pops up, written by John Carey and Michael Teshido, which has a suggested diet. In my experience, it's usually only patients with mild symptoms who respond to that, and it's probably a 20% response rate. So it's fairly low, and it's almost impossible to do a dietary study, in all honesty. Like, controlling people's diets for 3 months is phenomenally expensive. So no one's ever gonna do a diet study for vestibular migraine. So I think it's a reasonable thing to do, and I've had a couple successes over the years, but not many. Yes?
Often when you get MRIs for this group of patients, I never know what to do beyond, say, go see neurology when the MRI report states T2 flares, competency, chronic migraine. What do you do for this?
I skipped my clinical Pearl slide. But the first one is minor brain, I was ready for you. Minor brain white matter abnormalities are very commonly seen on FLAIR T2 sequences. Reassurance is the most important for those findings. I think they're a normal finding with migraine. The radiologists sometimes use alarmist language, like it's micro neuroinflammatory or microvascular disturbances. I don't think so. I think it's a normal migraine marker. Maybe if we do more studies, we could figure out, is there a pattern of clustering with vestibular migraine that's different than migraine headaches? Maybe it means something. I'm sure it's not coincidental. It's probably a sign, like we've been talking about this whole time, that migraine actually damages things. But it is a migraine marker, so I just reassure patients. Oh, yeah, sorry. That's a really good question. I don't do a ton of it, but my headache neurologist will use a burst, especially to try to jolt someone out of a really bad chronic. And I think it's very reasonable to try. Yeah. There is a inflammatory component to all this, which we didn't get into, but that's probably why, COVID and COVID vaccination and things like that can trigger migraine symptoms. So I think it's a very reasonable strategy. Yes?
Have you seen a change with the supplements you recommended? Is there one particular supplement that has it all the time, or do you stick with the rest of the supplements?
Usually the easiest way to do the supplements is combination pills, so that way they don't have to buy like magnesium, riboflavin, feverfew, et cetera, separately. So there's Migravent or Migraleaf are two commonly used pills. I have not seen a lot of treatment success with those. So I guess I don't know, but I don't think they're super helpful. But a lot of patients like to try them, and the side effects are really not that much. Enough magnesium can give you diarrhea, but other than that, they're well tolerated. All right, thank you all. Nice job, Brad. Thanks.
All right, we have a 30-minute break, and we'll resume the programming at 10 o'clock with the head and neck oncology block.
I said, do I have to sit there the
Oh,
whole
wait,
time?
wait, wait. Hey, that, hold on. Let me
I
turn
said,
this
do I
down.
have to do this? Come on.
All right, well, I think we'll go ahead and get started on the second session of the morning. It's my favorite session, the head and neck session, but we're all packing into one, so got a lot of good stuff for you planned. Let me first begin by introducing our invited guest speaker. It gives me great pleasure to introduce Dr. Ted Technos, who was one of my fellowship mentors exactly 20 years ago when I was at University of Michigan. And looking back, I feel so privileged to have been at Michigan, where there was just an incredible group of mentors that I had that included people like Greg Wolf and Carol Bradford, Doug Chapea, Ted Technos. Mark Prince was a new attending at the time. He's now the chair there. But I think it was an open secret. Ted Technos was always our favorite among the fellows and residents. And so it's been great to continue contact with him over the years, and no surprise that his career really continued a meteoric rise. After leaving my fellowship, he would go on to become the head and neck division chief both at Michigan and then later at Ohio State. He was the former chair of the Department of Otolaryngology at The Ohio State University. And most currently, he is the president and scientific director at the University Hospital's Simon Cancer Center, the deputy director of the Case Comprehensive Cancer Center, which I learned recently includes Cleveland Clinic as well, but all housed at where he's a professor of otolaryngology at Case Western Reserve School of Medicine. So let me introduce our first speaker of this session, Dr. Ted Technos.
Thank you, Steve, for that very nice introduction. You know, it's a real privilege to be here. First of all, because two of my favorite trainees are on the stage with me here, both Steve and Dr. Baker. You crossed paths, and it was a real privilege to work with them. I also want to compliment the department here. Great department, great collegiality, really outstanding residents and faculty. So it's been a lot of fun to get to know everybody. So the other thing I want to compliment is this meeting, because it's a very well thought out and a lot of real practical advice and practical lectures. And I'm about to ruin that by giving you a lecture that's completely depressing and probably of no use to anybody but Mike Kupferman, who just joined. But this is really a sobering discussion about where healthcare is headed, where it is, where it's headed, and how it's going to affect cancer care in the future. I don't know why Steve wanted me to give this talk, but I'm glad he asked me to. So here's kind of the current state of cancer care, and this isn't just head and neck cancer care, it's cancer care in general. Right now, cancer care is a fee-for-service enterprise. You know, I always love this cartoon, you know, where, you know, here's the doctor's office. It's like the old McDonald's, you know, 2 billion served or whatever. Go through, you have a procedure, you pay, and that's the fee-for-service model. We get paid for doing surgery. You know, medical oncologists get paid for sitting around doing nothing. No, I'm just kidding, but for giving chemo, and so on and so forth. But here's a question. So how much of cancer care do people think is outpatient? And I used to do an open poll in the audience, but nobody answered. So I'll tell you, it's 67% of cancer care is outpatient. So 2/3 of cancer care is outpatient. And this is the part that amazes me. So, you know, I recently became president of University Hospital's Seidman Cancer Center. It's a freestanding cancer hospital. We have 23 hospitals, so it's a very big health system. And it's about $5.5 billion, the health system. And cancer is half of all the revenue of the entire system. What's more amazing, though, is guess how much of that $5.5 billion is chemotherapy? $1 billion of $5.5 billion is chemotherapy. So medical oncologists are valuable, even though we often question that. No, I'm just kidding, but they are incredibly valuable to a healthcare system. So the answer to that is half of a health system's margin is cancer revenues. And I kind of gave away this next question, you know, which services contribute most to a hospital margin? Is it the med-oncs, rad-oncs, or surgical oncologists such as us? And it's medical oncology, actually. If you look at all the technical revenues and all of that, medical oncologists actually contribute the most to the revenue of a healthcare system. A busy, I always give this example, a busy breast oncologist, because I looked at the numbers, by having a busy practice, individually contributes about $40 million to the bottom line of a healthcare system. One medical oncologist. So, and again, it's all because of the technical revenue with the chemotherapy. Now, I don't know how the payer mix is here for all of you, but in Northeast Ohio, about 60% of our payers are government payers, Medicare, Medicaid. And the commercial business is getting smaller and smaller. So is that about what you guys are, Steve, or somewhere around there? Okay. So it's pretty consistent. Now, where are we today? So today we're still in this model, fee-for-service, where, as I described, you sort of get paid for doing your individual service. But what's happened, and that puts the greatest onus on the payer. So the insurance company sort of has to take the risk in that model by paying for these services and collecting, insurance rates. But as we go to the right, and this is what's happening now, more and more cancer care is getting pushed to the right, where the risk is really coming the provider, the hospital, and individual practices, so on and so forth. So right now, we're sort of in this phase right here in cancer care, where it remains fee-for-service, but there are performance-based models that are being developed. And as I'll describe, there's even bundling that's coming on board. And what bundling is, as I'll explain to you in a second, is where you get one fee for the entire episode of care. So that is coming and has come in some cancer models. And then the ultimate sort of challenge is when you have full risk global capitation. That's when a practice will be paid X amount of dollars to take care of all their patients for the year. And if they don't spend those dollars, they keep them. And if they go over, they lose money. So that's kind of global capitation where the provider is at full risk. So there's no question that for eternity, payers have been at risk, but this is getting pushed more and more to the right. So here's a bundle, and this basically, so what a bundle is a patient gets admitted to the hospital. This is an example. Day one, they have, their head and neck cancer surgery or their FES or whatever. Then they get discharged to a post-acute center. They have a follow-up appointment with the patient, with the provider. They're discharged to home. And the typical bundle is about 90 days. Cancer bundles are actually 6 months. So a bundled payment is where you receive one payment for all of this. So this is, the bundled payment initiative that the government has instituted. They're already doing this for joints. They're already doing this for heart failure. They're already doing this for other things. And cancer is kind of the next frontier. So the problem is only a third of cancer care is delivered in the hospital, as we talked about, and 2/3 of every bundle is in the SNFs, in the rehab hospitals, in home health, and we don't control that as surgeons or even as hospitals. So you need to really be wary of these things as a provider. And at my health system, at university hospitals, in order to be prepared for this, we actually have purchased post-acute facilities, home health, hospice, so on and so forth, so that we can actually control costs across the whole continuum of care. So there was a shared savings plan that was instituted about 7 years ago, and it was called the Oncology Care Model. So what that was, it was a 5-year program, as it says there, and the aim was to provide the best value for chemotherapy delivery. So you can see here, it was a 6-month episode. The target population was Medicare fee-for-service patients who were receiving chemotherapy. And there was about 180 institutions participating nationwide. And to sort of offset the costs of the program, you would receive, as a provider, $160 per patient per month as a influx of resources to be able to manage patients. And essentially, performance was measured by some quality and process measures, but we were supposed to cut 4% costs in this by doing the following things. We were supposed to, provide evidence-based practice, so tumor boards, and we had a kind of an evidence-based model of care called Via Oncology, which would do evidence-based care. There was improved access through call centers and, people reaching out proactively to patients. There was navigation, there was patient care plans that were a requirement, and then we had to participate in the Quality Institute and submit data to Medicare. So how did we do by doing all this stuff? So basically, actually we did pretty well. So admissions decreased, urgent admissions, and pretty much in every category, things got better. We had more patients going to hospice rather than, passing away at home, fewer patients who were admitted to the ICU within the last 30 days of life, fewer patients who were receiving chemotherapy within the last week of life, so on and so forth. Emergency room visits decreased dramatically, but total cost of care went up by 20%. We didn't reach the 4% decrease in total cost of care. And if you look, and you can't see this, but this orange bar is what contributed the most to the cost of care, and it went up from $1,700 per patient per month up to $2,700 per patient per month, and that was all pharmacy. So it was all the drugs, biologics, all the medications that the patients were receiving, whereas every other part of care that we can control was favorable. So we failed. We didn't get any benefit from this, and now there's an OCM Part 2, which we refused to participate in because they didn't take out drug costs. But these are the types of things that the government is trying to do now and that we're all going to have to participate in at some point. There was another project, I won't go into this, but this was also for hospice care. It was this Center for Medicare and Medicaid Innovation Grant. So we had PAL Care, and it basically decreased the cost of care in the last 90 days of life and decreased admissions and improved patients' quality of life. So there are definitely benefits to the patients, but it's not saving costs. So what are the trends now, and what's the government and the payers doing about this? They're concerned about this because these costs keep escalating. So how are we supposed to prepare for what's coming? So here's some data. Cancer is a growth field, unfortunately. We're expecting 10% growth in the number of cancers over the next 5 years. And that's primarily, you can see, lung cancers, hematologic cancers, the cancers of aging, more or less. So there is going to be more cancer in the future, not surprisingly, as the population ages. And there's also going to be more outpatient growth in the next 5 years, and that's primarily because of screening and outpatient surgery. Inpatient is decreasing, so there's about a 1% growth expected for inpatient cancer care. So, it's primarily growing on the outpatient side, but if you take out screening and if you take out surgery, there's actually expected to be a 3% decrease in oncology utilization, primarily because of new technologies. So many of you may be aware, hypofractionated radiation now is very common. So instead of getting 30 treatments of radiation, people are getting 5 for prostate cancer, for breast cancer. So the 30 episodes are being decreased pretty substantially by these hypofractionated radiation regimen. And also case management has resulted in fewer days in the hospital as well. So there are challenges to the economics for a healthcare system as we can see with these trends. And you can't have a talk or you can't go out to dinner and not talk about COVID, so I have to throw COVID in here. So COVID has changed the marketplace significantly in these 3 ways. We all know that people have avoided care, so patients are coming later to us, larger disease burden, and there's a backlog of cancer cases. The problem is payers are trying to meet patients where they're at, so they're pushing as much as possible, to do telehealth, and they're also trying to push care closer to home. So payers don't want to pay for hospital-based services because those are about 2 times as expensive as delivering care in the office. So they're pushing more and more for care to be in the office and not in hospitals. So all of that has sort of been accelerated because of the COVID pandemic. But these are the things that really the market is showing with regards to controlling costs in cancer, which is a top priority for society, really. And I'll talk about each of these 3 in sequence. So payers are really trying to cut the costs of oncology care through several strategies. When you look at commercial payers, this is the Aetnas, the commercial insurance, they are trying to shift things to the outpatient setting, to lower cost settings. So for those of you who do cancer care, you may have noticed now that checkpoint inhibitors, at least where I work, they don't want them infused at the hospital. They want them infused at outpatient facilities, that we call doctor's offices. It's really not doctor's offices, but it's not labeled as a hospital facility. So when we give a combination of a checkpoint inhibitor and chemo, we actually have to send the patient to an outpatient setting and still do the cisplatin or whatever they're getting in the hospital. So patients are having to go to 2 different places because that's what the insurance companies are trying to do to decrease costs, which is, patients don't know that, they get mad at us, but it's really the insurers that are driving that. The other thing is commercial payers want us to purchase drugs from their pharmacies. They don't want us to deliver it from our pharmacies. So there's this white bagging policy where a patient actually has to order the chemotherapy, especially oral chemotherapies, from a specialty pharmacy and then bring it in to be delivered rather than us providing it and having the revenue for that. And also they're just making it harder for us to do anything. Surgery, everything has to be prior authorized. In Ohio, I don't know how it is in Arizona, but we have to wait 10 days for prior authorization. So even if we see somebody today and want to operate on them tomorrow, oftentimes we can't do it because of that. And then the government is also trying to cut costs. So they're directly cutting reimbursement. You always hear about how reimbursement rates from the government are going down for Medicare. And they're testing these value-based models that I described to you. So this is the part that's really, I don't know, I guess I'll call it criminal. So all these insurance companies now are all vertically integrated. So these are, United Healthcare, Aetna, Cigna, Anthem, all of them. So if you start at the bottom, they now own physician practices. So these insurance companies have bought up a whole bunch of primary care practices. And when the primary care provider, and specialty practices, by the way, it's not just primary care, but when these folks prescribe a medication or say that a person has to have surgery, but let's just stick with the medication, you have to buy it from their specialty pharmacy. So if we use United Healthcare as an example, they have Optum Care, there's 20,000 practices around the country. They have to get their drugs from either Optum RX or Briova RX. So this is a prescription benefit manager. These are the people who buy all the medications and distribute them. And their specialty drugs have to come from here, so that essentially they own the entirety of care delivery and drug delivery. And they've all done this, and all of them, are reaping the benefits of controlling patients from the primary care office to drug delivery. They're also essentially affiliating through payments, through ownership acquisition, and then new capacity. And these are just two examples. Optum, which is United Healthcare, they have 20 million patients under their control in their Optum Care division, and they're all going now to value-based arrangements. So a primary care doc is going to send their patients to a surgeon who is the lowest cost surgeon. And we're going to have to track that as surgeons, because they're going to be on the hook for it if they send you to a high-cost facility or a high-cost surgeon. Academic medical centers are the highest cost places in the world. So they're not going to be inclined to send these patients to academic health care systems unless we start to cut costs. Similarly, you can see they're acquiring additional affiliated physicians, and then they're expanding this capacity. They're opening clinics. And this is all the insurance companies doing this, not hospitals or academic medical centers. Employers are also looking to cut costs. So many employers are self-insured, so they want to make sure that one of their biggest costs is providing health insurance to their employees. So employers are looking to do more virtual care, but I think the most frightening thing for us are these centers of excellence. So what they're doing with that is they're putting out a petition, and they're saying to their employees, if you need to have a parotidectomy, as an example, or a major head neck procedure with a free flap reconstruction, tell us how much you can do it for, and if you can do it cheaper than anybody else with good quality and low costs, we'll send all our patients to you. So at university hospitals, we actually have these arrangements now with GE for knee replacements. So any patient in the GE system who needs a knee replacement comes to UH to get it done, because we can do it cheaper than other places. Similarly with Walmart and bariatric surgery. So we have a similar arrangement with that. Now they're doing this with cancer care. So there are going to be centers of excellence that are going to be set up. And then the other part of this that employers are trying to do is they're requiring their employees to have a virtual visit with a primary care provider before seeing a specialist. So they set up these, virtual care plans, and you can see there's already a bunch of them existing. And this is the part that really cracks me up here. So Humana gives all their members a digital blood pressure cuff, a thermometer, and a log that they submit virtually to their providers. And all referrals have to go to a, quote, high provider network within Humana, where they can prove that that is the best value, cheapest cost in their system. But this is the center of excellence thing that I was telling you about. When somebody does need a procedure, they've created these hyper-narrow networks where they say, okay, everybody from a region is going to get funneled to these highest value surgeons because they have the best outcomes for the lowest cost. And that's how they decide where to sort of make patients go if they're diagnosed with a surgical problem. I'm going to skip over this. This just goes over the white bagging policy. 90% of administrators have said basically now that our patients have to source their drugs outside of our system and bring them in. So it's becoming more and more popular, and that's going to eat into hospital profitability and the ability to support, our physicians and our programs. Prior auth is also a big problem, especially in radiation oncology. So because it's such a high-cost service, many times they're not approving some of the treatments, or are questioning, does this patient need proton therapy? Does this patient, really need 30 treatments? Can they do hypofractionation? So on and so forth. And then the government, of course, wants to cut reimbursements and do these alternate payment models. One of them was supposed to start in radiation oncology, but luckily it was delayed, where they pay a bundle for a radiation treatment. And that was expected to save about $230 million. I talked about this. 340B, for those of you who don't know what that is, that's how a hospital that serves underserved individuals, or serves a region that has underserved individuals, gets a big rate cut, about 28% on drug costs, and then we charge Medicare full rate, but then we use that to, care for the underinsured and create programs. But that was proposed to be cut in its entirety, and the government, the courts upheld that cut could not occur. But they're certainly coming after that, and then, and then again, this is where we're allowed to negotiate drug prices, and over a coffee, I can tell you some crazy stories about how much patients have to pay out of pocket to get chemotherapy that costs about $1,000, but Medicare charges $180,000. Cisplatin, perfect example. Cisplatin, to source it is about $1,800, but patients get charged $180,000. Their insurance does. And if they don't have insurance, you cannot charge a patient less than 25% of Medicare. So even though it costs $1,800, a patient has to pay out of pocket 25% of $180,000 for cisplatin, which has been around for 50 years, which is insane. So I told you this was going to be depressing. All right, so these are some strategies that you have to do, to stay up to date. The other thing that's really important in cancer care, and this is long overdue, is that there is an urgency now to really make health equity a strategic priority for healthcare systems. Not that it hasn't been before, but certainly this is accelerating, with, all these populations that we serve that clearly have worse outcomes. And we're going to be judged as a healthcare system on how well we address these things. And these are expensive things to do, because you can see what you got to do is, you certainly need to have translators, you need to have outreach coordinators, you need to have navigators. And in order to be CMS eligible, all these programs need to be bolstered. And you can see lots of hospitals actually aren't doing a lot of these things, and it's going to be a requirement to participate in CMS in the future. So that is a very important initiative. And then the last thing I want to talk about with you here is these non-traditional competitors now that are coming into cancer care. So there are non-traditional competitors that are already in oncology, then there's non-traditional competitors who are coming from outside. So the ones that are in oncology are basically all these oncology practices. So you may not be aware of this, but about 72% of medical oncologists are in private practice. And most of them are in an office of 2 to 5 people. So it's very expensive to run an office. So these US Oncology, One Oncology, Genesis Care is buying up all their practices, and they're saying, we're going to make you more efficient, we're going to give you Epic, and we're going to order all your drugs, and we'll take the burden off of you. So they've acquired all these practices, and they provide them with the infrastructure, but you already know how they're already organized vertically to get all the agents. So that's that's the reason they're doing it. They're not doing it out of the goodness of their heart. And also, these Center of Excellence programs are being created. And you can see these are private and academic partnerships many times. Mayo and Walmart has created a Center of Excellence in cancer. City of Hope has created a process for virtual second opinions, and Memorial has created a Memorial Sloan Kettering Direct program as well. What's even more concerning are these non-traditional competitors like CVS, these alternate ambulatory sites where patients go and receive concierge practices or concierge services, and they're referred to preferred cancer centers that are lower cost. And these population health managers where, you know, they're fully capitated, so they get one payment to take care of patients, and they only direct patients to the lowest cost settings. This is just an example of the growth in these one oncology programs where they, you know, bought 62 practices, or they went from 62 practices to 148 in 1 year, and they keep buying up independent oncology practices. And then Genesis Care, which, believe it or not, is based out of Australia and New Zealand, spent $300 million to buy U.S. oncology in the U.S. so that they now have a footprint both in Australia as well as here. And they're private equity that is basically disrupting cancer care by doing all these things. These are these Center of Excellence programs. Memorial, what they do is they actually do in-person treatments for thyroid and breast cancers. They fly them to New York and they take care of those because those are one and done sorts of treatments. But they do remote diagnosis and planning and coordination at other parts of the country for other diagnoses. And Access Hope is actually a virtual second opinion that goes through City of Hope. And then the last of these, as my time is running short, are these population health managers, where ChenMed has 75 centers in 10 states, and they have a panel of patients, and they're given a capitated budget for that panel of patients, and they have to manage to that amount. And as you can see, these are expanding greatly, and they shift only to high-performing hospitals and centers and doctors. So they will know sort of your quality scores as we make our quality scores more public, and they'll only direct patients to doctors who have the highest quality scores and hospitals that have the highest quality scores. And then finally, you know, we have, you know, the CVSs of the world, urgent cares, virtual clinics. 20% of consumers prefer these sites over traditional sites of care. And this is only going to increase as, you know, the millennial generation has got their faces buried in phones all day. They're not going to want to go to a hospital to see a doctor. They're going to want to do it at home. So these are the competitors these are the challenges. So hospitals and healthcare systems have to be prepared for all this, as do we as surgeons and as providers. So here's, you know, the takeaways. We have to look at viable alternatives, you know, for us as hospitals to move infusions out of the hospital settings into the outpatient setting. We have to provide high-value care at the lowest cost, which is really hard to do in an academic medical center, especially hard to do at the PPS centers like where I used to work and where Mike used to work at MD Anderson and the James. There's 11 of those that are super high cost, so they're probably going to be squeezed out of this altogether in the future. And then we have, we have to remain informed about all these so we can address them in the future. So this is Cancer Hospital that I work, Seidman Cancer Center, and I thank you for your attention, and I'm happy to take any questions if there are any. Thank you.
Anyone have any questions about this?
Don't shoot the messenger. I remember whenever somebody would give these talks, I was in the audience, I would get so mad at them, but it's not me doing it. I'm just sharing the information.
All right. Okay. Well, we'll now at this time switch kind of back over to more clinical, hopefully practical clinical issues, and I'm going to give an update on salivary gland tumors. I'm going to mostly focus on the parotid gland, which is the largest gland, and I think is a particular interest for a couple reasons. One, management of the facial nerve creates a variety of unique issues. Also, it's the only gland that has lymph nodes in it, so in terms of evaluation, you have to look at whether it's something that's arising from the salivary gland or from lymph nodes within the parotid gland. Most of the tumors I'm talking about, though, also can affect any of the salivary glands, either major or minor, but some of them have certain predilections for one or more of these glands. So moving to first start talking about benign neoplasms, pleomorphic adenoma or benign mixed tumor is the most common benign salivary tumor. Histologically, there's a diversity of morphology with both mesenchymal and epithelial elements. I think clinically the important thing is principles of surgery is complete resection, preferably with a cuff of normal tissue around it, because otherwise there can be a high rate of local recurrence, and certainly tumor spillage is something that is really key to avoid in removal of pleomorphic adenomas. The second point that, to review is that known, although small, risk of malignant degeneration, which can occur particularly with long-standing pleomorphic adenomas, and can reach about 10% at 15 years of history. Warthin's tumor is the second most common benign salivary neoplasm, mostly in males. It has a very characteristic histologic image. I remember this used to be a favorite on board exams, and even if you're not a pathologist, that sort of appearance of those cystic spaces with papillae fronds are very characteristic. It similarly can be treated with excision, but it's also important to note that unlike pleomorphic adenomas, there is no malignant transformation that can occur. And so in some occasions, observation is very reasonable, particularly in older patients. Now, one thing I've found in my experience that I don't see so talked about, but I've had a number of patients who have problems with recurring infections, and I think it's because of those cystic spaces that you see in there. And actually, some of the hardest prioritization I've done have been in patients who've had, recurring infections, and sort of that inflammation and scarring never goes away. So I've kind of gone back and forth, but I now tend to actually favor excision in an appropriate, healthy patient with Warthin's tumors. I mentioned this one because although it's always listed as rare, I seem to have encountered quite a few of these. Oncocytoma, again, mostly in the parotid. What I found about these is, one, they can be multifocal or bilateral, and they also, kind of similarly, or maybe even at greater risk than pleomorphic adenomas, can sometimes recur if they're inadequately removed or if there's tumor spillage in their initial resection. Histologically, they have these rather bland mitochondrial-rich cells called oncocytes. Another related phenomenon that I have encountered is oncocytosis, where actually the parotid tissue can kind of be taken over by these oncocytes, and that can actually be very, very challenging. They get parotid enlargement that I've had to actually just debulk just because of those issues, but they're difficult to manage. In terms of malignant neoplasms of the salivary glands, mucoepidermoid is probably the most common. Its name derives from its two main cellular components. Important thing to note when it comes to salivary gland malignancies, that grade is very important, and that's in contrast to, for example, squamous cell carcinomas, where that's not so important. But with mucoepidermoid carcinoma, low-grade tumors can be treated with surgery alone with a very excellent prognosis, whereas high-grade usually requires surgery plus adjuvant therapy and a lower 5-year survival. Adenoid cystic carcinoma, really biologically, is one of the most fascinating tumors in my mind. It has a slow and indolent, but really relentless course. Perineural invasion is extremely common. Again, the histology, or if you want to say grade, is also important for this tumor as well. The classic cribiform pattern is up here, and then this is tubular, which has the best prognosis, and solid having the worst. And treatment is generally focused on surgery and usually adjuvant radiation therapy to get local control. But really the problem is distant metastatic disease, which can occur up to 20 years later. So these patients have excellent 5-year survival, but that drops off as you get further and further out. It's also important to note, though, that because of its indolent course, people can live with disease for quite some time. Distant metastatic disease can be treated with radiation or some forms of targeted therapy, but generally only if they're symptomatic. There's a laundry list of additional salivary gland malignancies, which I won't go through, just to mention a couple, as I mentioned. carcinoma ex pleomorphic adenomas are malignancies that arise from previously benign pleomorphic adenomas. This is a very aggressive salivary duct carcinomas that you'll sometimes encounter. Histologically, they have some similarities to mammary ductal cancer, but these tend to be high grade and poor prognosis, and oftentimes a lot of lymph node metastases. So let's talk a bit about evaluation of a salivary gland mass. This is a patient who presents with a upper neck mass, a mass in probably in the tail parotid region. Initially, the differential diagnosis is what you would generally think of in terms of a neck mass. And I would point out, for example, with salivary, with parotid enlargement in particular, we do still see HIV sometimes presenting as a cystic parotid. Autoimmune diseases like Sjogren's and sarcoidosis could also present as salivary gland masses. We're going to focus mostly on neoplasms, and again, the distinction between benign versus malignant. And then for parotid, the malignancy can either be arising from the salivary tissue, or it can be, for example, a metastasis from one of those intraparotid lymph nodes. Variety of imaging that can be used. I would say MRI is the best when it comes to salivary gland neoplasms. Ultrasound, seems to be kind of in vogue, particularly among primary care docs, to get diagnostic ultrasounds of the neck. I don't really find them that useful for salivary gland, but they are very useful, for example, with needle biopsies, which are very reliable, particularly in distinguishing, for example, with the parotid mass, what's salivary and what's non-salivary. You always hear it, occasionally it'll be, you'll have what is, benign mixed tumor on cytology that turns out to be a low-grade malignancy, but I would say that for the most part, the treatment is really about the same anyway. So MRI, because it provides really superior soft tissue delineation, is the preferred imaging modality of choice. This is an example of a pleomorphic adenoma, which on T-weighted imaging is well circumscribed, intermediate or hypointense on T1, and then hyperintense on T2. Malignant tumors tend to have more of an infiltrative, poorly defined borders. Here's an example of a mucoepidermoid carcinoma. You see the irregular borders, involvement of the deep lobe. As I said, CT is not as useful, but sometimes it's done, particularly in terms of the initial screening test. But it does have one very helpful use. It's great at identifying, in this example, a parotid duct sialolith. So worried about PET CTs. These really aren't very useful for initial imaging evaluation of the salivary glands. Part of the issue is that normal parotid tissue, for example, has uptake on FDG. Many of the inflammatory infectious processes which can affect the salivary glands can appear similarly with FDG uptake. Its main utility, I would say, is that in case of a known salivary gland malignancy, it can be useful and is used for evaluating metastatic disease elsewhere. The other thing that I encounter sometimes that I'll mention is, not uncommonly people get PET CTs if they're, under surveillance for some other cancer, lung, prostate, breast cancer, and then you have these incidental FDG-avid parotid masses, and they get referred for evaluation. To point out that one study showed that, only about half of those were actually malignant, and many of them end up just being benign neoplasms of the parotid. But this is important because the patients are generally come to you very panicked. They think they have, a metastasis from their other cancer in the parotid. So then, talking about treatment, as mentioned, whether it's a benign or malignant salivary neoplasm, surgery is generally the initial treatment of choice, and an en-bloc complete resection is the principle. Observation may be reasonable, as I mentioned, for some benign neoplasms. For a benign or a low-grade malignancy, parotid neoplasm, parotidectomy with facial nerve preservation, no need for radiation, no need for elective neck dissection. So when we talk about a superficial parotidectomy, just wanted to share with you some clinical pearls and tips. Probably most of you do this operation. I think it's one of the more fun and cool operations that we do in otolaryngology. I think the importance here, though, is that this is one where safety as well as efficiency are the key principles. And when you do that, you should have really, really excellent results. I think in keeping those principles in mind, facial nerve monitoring I think makes sense to use, regardless of whether you need it or not, but it's helpful in terms of safety and efficiency. So I use a 4-channel NIM monitor. Having a bloodless dissection on the nerve is really important. I find that hemostatic saw scalpel useful, if you're not familiar with that. It's heat, so there's no electric cautery, and really, because you're working around the nerve, monopolar cautery is something that I would recommend avoiding. So this is the skin incision that I use, a modified Blair skin incision. Some people use a facelift incision, but in any case, I think this works pretty well. And then here, skin flap elevation. Using the saw scalpel really gets a nice bloodless dissection. I think a thick flap that you elevate right over the parotid fascia is good, not only because it's relatively avascular, but it also has been reported to help or at least decrease the severity of Fry syndrome by having a thick flap. And then the next step that you want to do is separate the tail of the parotid from the sternocleidomastoid muscle. Again, that's generally a relatively avascular plane, and you go down that all the way till you find the posterior belly to digastric. You can start to move along. This here is the tragal cartilage. Continuing to dissect along that tragal cartilage down to the tragal pointer, and that digastric muscle marks the depth of the location where that facial nerve main trunk exits from the stellomastoid foramen. I wouldn't typically put a blue piece of paper there, but that would just illustrate the anatomy of that main trunk of the facial nerve. And then really, so, no matter how, bloodless you try to make it, you are, kind of in a deep hole there. So I think really the key is you want to move very quickly from when you have the main trunk identified to trace that out until you get to the pes. The technique is, using a dissecting hemostat, something like this, to go along the nerve and then dividing that parotid tissue superficial to the plane of nerve. This is the saw scalpel again, which again I think is helpful in terms of dividing and coagulating at the same time. And then once you get to the pes, it's really, you want to serially dissect out the branches of the facial nerve. I usually start from whatever is farthest away from my mass. So if the mass is predominantly over the lower division, then I'll start at the upper division and then just go branch by branch through each facial nerve. And that's gently raising the superficial parotid and the mass off and freeing it up completely. So you have here the completed superficial parotidectomy, and you have your branches of the facial nerve nicely exposed out and preserved. So in terms of the common complications after parotidectomy, sialalocele is probably the most common and kind of expected. And this is related to having those kind of raw cut edges of the salivary gland. Takes a while for those to sort of heal up, and so in the meantime, they can leak out. And oftentimes this doesn't start right away, so putting a drain in afterwards doesn't really alter this. It's when they get home, they're back on a regular diet, their saliva production comes back up to normal, that you see that. But these are generally self-resolving, and drainage, as I said, is seldom required. Fry syndrome, I think you're all familiar with that. It's probably reported by up to half of patients in some studies. I haven't found it to be particularly bothersome to patients, but there are some strategies for treating people who are bothered by these symptoms. Facial paralysis is generally, I think, the dreaded complication. Transient paresis just from the dissection in the literature is actually pretty common, probably around 25 to 30% of the cases, but obviously a permanent paralysis from direct injury should be rare with this operation. Ear numbness. So I didn't mention in terms of, there's some controversy in terms of management of the greater auricular nerve. I will say if it's convenient, I will save it. I haven't, to be honest, noticed much of a difference in outcome in terms of its effect on ear numbness, but you can certainly preserve it or not. Most patients will have some degree of transient ear numbness afterwards, and again, it's just really sort of managing and explaining to the patient so they're not, so they're reassured. I think that the contour deformity is something that I do mention. It's, I think, probably really, they ask me about the scar, and I say, well, it's probably the contour that's probably more noticeable. Again, I haven't found a lot of patients that are overly concerned about it, but there are some techniques that you can do for that. So next I'll move on to principles of management of malignant salivary neoplasms, again, kind of focusing on the parotid. And in terms of the parotidectomy, in a lot of ways, it's really the same surgical principles. You want to complete en bloc tumor resection. Manage the facial nerve, something that always is discussed with this. The principles of facial nerve management, if it's working preoperatively, then all efforts should be made to preserve it with your parotidectomy. If it's not, and indicating that you have a deficit and you have involvement of the nerve, then you can plan on and expect that you want to resect the whole tumor, which is going to include the facial nerve, or if you encounter such a finding intraoperatively. When you do have to section it, preference is to do immediate grafting, and really that's where the great auricular nerve comes in very handy. You have a great cable nerve graft that's already in your field, and so you can do that at the same time as a radical parotidectomy. Management of neck for malignant salivary neoplasms is another area that has been controversial. As I said, for low-grade malignancies, there is not a need to do elective neck dissection, but in terms of high-grade, that's where I think there's been some debate. I think that for a high-grade malignancy, you are likely going to be treating those patients with adjuvant radiation therapy. I think if you compare the control of the neck with elective radiation versus elective neck dissection, it's probably comparable. On the other hand, if you're doing a parotidectomy, in some sense, I think it makes sense to go ahead and do the elective neck dissection, have some more definitive pathologic information. And so I will generally do it at least sort of levels 2 through 3 when I know that I have a malignancy that's potentially high grade. And then if there is known nodal disease, then a therapeutic comprehensive neck dissection should be done. In terms of adjuvant therapy, because again, to say that primary surgery remains the standard of care for salivary gland malignancies, but adjuvant therapy should be used in cases of high-grade malignancies, cervical node metastases, or in cases where you are unable to resect the primary tumor with negative margins. So the last topic that I want to go over, because I think it's kind of cool, is the parapharyngeal space. And I'm including this because some of those parapharyngeal space masses are in fact salivary gland neoplasms. The anatomy of the parapharyngeal space has traditionally been divided into a pre-styloid and post-styloid region, and the carotid and IJ, kind of the great vessels, kind of define that. In the pre-styloid space, these are often either deep lobe parotid neoplasms or they can be minor salivary gland, but they're typically salivary gland origin. These masses are often not palpable on neck exam because of their location. They may present as a submucosal oropharyngeal mass, or they may simply just be an incidental finding on imaging. Here's an example, pretty subtle. It turned out to be an oncocytoma in the parapharyngeal space. This was not palpable. It's in the pre-styloid area because it's anterior to the vessels. This is another example of a deep lobe pleomorphic adenoma, again in that classic pre-styloid region, anterior and medial to the vessels. So in terms of surgery for these, I think it starts out with, everything is directed towards optimizing that exposure of the parapharyngeal space. And so it starts with positioning, neck extension, turning to the head. This is also, I think, helpful, nasotracheal intubation, by getting the tube out of the mouth. You can more readily occlude the teeth and actually pull the jaw forward, and this can give you about an extra centimeter of exposure. You can even sublux the TMJ to give you more exposure into the parapharyngeal space transcervically. I've never had to do a mandibulotomy, but that's certainly a possibility. The incision and the initial steps for me are the same as a parotidectomy, so that's part of why I don't have any images to show you. You start out by separating the tail of the parotid from the posterior belly digastric. I identify and trace out the main trunk and sometimes the lower division of the facial nerve. I know it has been described of not doing facial nerve identification, so I acknowledge that that's something that some folks do. I do it for a couple reasons. One, I just like having that nerve in my site, so I know I'm not going to inadvertently cause any traction injury to it. The other reason that I think it's helpful is because it's part of what helps to open up that space that you need. And so really the main area that you're working is kind of deep to the mandible, which is obviously it's a bony hard surface. But between the mandible and the posterior belly digastric, and then on either side, it's helpful often to retract the posterior aspect of the submandibular gland forward, and then that main trunk of the facial nerve and getting some of that tail prod tissue out of the way helps open up that space. And it's often only at this point that you actually identify or palpate that parapharyngeal space mass. Sometimes in your way you have the stylohyoid ligament dividing that, or sometimes I have to divide that styloid process if it's long. Sometimes the internal maxillary artery is also in your way, and so having to ligate and divide that helps to open up that space. But really, once you get in there, it's pretty cool because there isn't a lot attaching the mass to anything else, so you can bluntly, sometimes even finger dissect out the mass and free it up. Sometimes it only takes a minute or so, and everyone goes ooh and ah. They think it's pretty cool. And then you're done. Because there's that potential dead space that's medial to the mandible, I use a drain and I put it into there and close up. I also know that people have talked about doing transoral approaches. I don't have any experience with that. Historically, it was condemned, but more recently, people have started to discuss doing it that way. I think this is a pretty cool way to do it, so I'm going to keep doing it this way. But that's all I have. So again, it's been a pleasure having you all here. And at this time, I'm really pleased to move on to our next speaker, who is my partner, Dr. Sheetal Borelli.
Okay, thank you all for being here today. My name is Sheetal Borelli. I'm a head and neck oncologic and microvascular surgeon, and I'll be talking about precision 3D medical modeling and how it applies to my practice in head and neck reconstruction. I have no disclosures. So what is medical modeling? It's essentially computer-aided surgery using and incorporating the personalized creation of these highly accurate physical models of human anatomy, so the skulls or the mandibles and maxilla, creating implants, creating cutting guides, and it's all created from personalized individual patient CT scan data. And so whether we realize it or not, we've all been kind of familiar with it. This is an example of a facial trauma case. This patient had numerous comminuted fractures, and as we're planning this surgery, it can be really difficult to figure out where all the fractures lie, and we're trying to process that 2D information and create this 3D construct in our mind, and that's what allows us to plan the surgery and effectively treat this patient. And so we asked the radiologist to create this 3D reconstructed image, and that's what we use to be able to plan that surgery. Similar concept in anybody who does sinus surgery. You use surgical navigation. You're taking 2D images and you're creating a 3D construct in your mind, and that helps you figure out where you are, help you figure out the structures that you're working around. So same concept for mandibular reconstruction or head and neck reconstruction. You can create these models of your patient, of their anatomy and their facial skeleton, just using their CT scan data. And that helps you, again, sort of in your mind, understand the patient's anatomy, the patient's pathology, helps you plan their surgery. And on the right side there is you can also have these implants created, these facial reconstruction plates, and that is personalized to the patient's anatomy. It fits perfectly to wherever you're trying to place the implants. It's not something you can create by bending a plate, so you can have it 3D printed. And why is this important? So, fibular reconstruction for the mandible is pretty complicated. And the reason why it's complicated is because you take a straight piece of bone and you're trying to create a curved mandible with it. And so the only way to do that is to make several cuts within that straight bone, similar to if anybody does carpentry, you're making miter joints in that bone. And you have to get the angles precise. You have to get the lengths of the bony segments precise, or your entire reconstruction can be off. And so in the operating room, this can be pretty frustrating. If you get the angles wrong, you're back there kind of just chiseling away at your bone, and it can sometimes take hours to figure that out. Here is sort of an example of how that's done. This picture is actually from a paper from Dr. Technos, using a plastic ruler, and essentially you're using that ruler as a template, and using it as a guide to figuring out your angles, your lengths of your osteotomies, and it's pretty good, but it's still a little bit imprecise. The middle picture is using tongue depressors, popsicle sticks, and I use that a lot too. And again, you're basically you're trimming this tongue depressor, you're trying to figure out the angles, and it can again just be really time consuming. But how do you do that with a case like this, where you have a fungating tumor coming right through the mandible, right through the chin? Normally, we try to put a plate around the bone, around the mandible, and try to pre-plate it, and that allows us to have some sort of guide in terms of our mandibular reconstruction. But in this case, you can't really do that. So, we're stuck using a lot of different techniques here, like MMF to try to get their teeth back into occlusion, and using the teeth and the occlusion as a guide to where we need to go. Here's another picture in the top right there of a lot of different clamps kind of put in place, and we're trying to figure out if the plate's in the right spot, and again, it's pretty imprecise sometimes. So I want to kind of show you a few examples of how medical modeling has really changed my practice, how it's really allowed me to do some of these more complicated cases and do it more precisely. This is an example of a 44-year-old woman. She had osteomyelitis of her anterior mandible. She underwent numerous debridements of her mandible in Mexico. All of her pathology was negative. It was kind of unclear sort of why she developed this. About a year later, she came to us, and she had essentially an anti-gump deformity, and she wanted reconstruction. And it's challenging because she did not have any teeth. And like I said before, we tried to use the teeth as a guide to determine where the bone should go. And so using medical modeling, we had all of her CT scans uploaded. I work with an engineer, essentially, to kind of figure out where the bone should go, and we're kind of manipulating the location and the angles of the bone. And in this case, chin projection was important. Without having teeth, they didn't know exactly how far forward the mandible should go. And so we were able to kind of figure out the perfect spot for it. The other thing that can happen in these cases, in these secondary reconstructive cases, the ascending ramus will tend to medialize, and you can have scarring of that. And intraoperatively, without medical modeling, you're essentially trying to reposition the ramus, reposition the condyle. And you have these two floating segments, and it can be very difficult to kind of get that part right. So with medical modeling, you can position the condyle perfectly, have it seated, and make sure that there's no medialization of the ramus. Here's what it looked like intraoperatively with the medical modeling plan. The other benefit of this is that, before, with the regular traditional freehand method, you have to wait for the defect to be created. And then once the defect is created, then you go up to use your techniques like the tongue depressor or the ruler to make your templates. But with the pre-planned medical modeling way, you can do all the reconstruction on the back table while my partner is finishing up the resection. And so in this case, I can make the cuts in the mandible, in the fibula. I can put the plate on there, and so when the resection is done, it's essentially plug and play. You can kind of just suture in the flap and do your micro, and so it cuts down on a significant amount of time. And that's sort of one of the main, I think, benefits of medical modeling is the efficiency that this allows us to do. Here's another example. This is not the same patient, but this is sort of taking that just a step further, where we can actually do all of this on the leg. And so I made the cuts on the leg, put the plate on the leg. I actually did not even take down the vessels yet, so we haven't even gone ischemic. Again, so this just allows us to sort of be ready to go once the defect is prepared. So here's that same patient on that anterior mandible defect. That's with the construct put back into place. Here's what she looked like immediately post-op. And so I think, her chin projection was pretty good, and I felt like this would be something difficult for me to do if I did not have medical modeling. I don't think I would have gotten it as nicely as that. She still had a lot of submental fullness there, and as time went on, a lot of that kind of shrunk down as the muscle atrophied. Here's another case of an anterior mandible defect. This is a 55-year-old woman. Whoops. She had an anterior floor mouth cancer that I actually treated 4 years prior. I did a wide local excision at that time. She had multiple positive nodes, extranodal extension, and so she went on to get chemoradiation therapy. And so knowing what I know now, I probably should have done a forearm flap, but I didn't. And so she developed osteorated necrosis of her mandible. And it was pretty extensive to the point where her submental skin was eroded as well. And so here's what her plan was. This was helpful because I could look at the CT scan data and I can determine exactly where the osteorated necrosis was. And sometimes that can be subtle intraoperatively with if you're just looking at the mandible. It can look pretty normal, and you may think you got all the ORN out, but you might, if you left some behind, they can recur. So using this technique, you can really look at your CT scan and figure out your margins. On this same picture here, you can see those white cutting guides. Medical modeling is incredibly precise. So if you're off with your cuts, then everything will be off. And so those guides are fit to the patient. It uses basically ridges and imperfections in the mandible, and the guide locks on to the jaw, and so it doesn't shift in any way. So it allows you to make your mandible cuts pretty precise. It's the same sort of concept for the cutting guide on the fibula. It allows you to make those miter joints, again, really precise, and then it fits into your defect nicely. The plate that you can see there is one that is 3D printed. And again, the benefit of this is that this is not a plate that you can bend by yourself. So if you took a stock plate, you wouldn't be able to create something like this. You'd have some sort of imperfection in the plate. This allows us to get the plate to be completely flush against the fibula and against the mandible. The other benefit of these plates is that because they are not bent to that shape, and they're 3D printed, they're actually stronger. So you can make these plates thinner, but also stronger than the stock plates. This is what you look like post-operatively. The skin paddle there was used to recon the submental skin. And then the picture on the right was about a month out. She actually had a little bit of skin necrosis on the distal aspect of the flap that subsequently sloughed off and then granulated in pretty well. So again, I think that her chin projection was pretty good. Actually, just going back to this, we actually set her chin back a little bit because we were worried about the ability to have enough bone for reconstruction. And that would be something I think would have been difficult to sort of plan during the surgery, not knowing how much bone I would have for the reconstruction. So we set her chin back a little bit, and it actually turned out, I think, pretty decent. Here's an example of orbital maxillary reconstruction. This is a 47-year-old man. He had about 3 months of pain in his left maxilla, as well as some loose tooth. He saw an oral surgeon. They extracted his tooth, they biopsied the soft tissue around it, and it came back as fibrous inflammatory tissue. And I saw him afterwards. I saw the CT scan and didn't really look quite right, did not obviously look benign. I redid the biopsy and it came back the same way. It came back as benign fibrous inflammatory tissue. But looking at the scan, it looked like there was pterygoid destruction, so we took him to the operating room and planned it as if it was a carcinoma. And in his case, his mass was involving the orbital rim, the orbital floor, and so we made our cuts to include all of that. And so this was a left total maxillectomy. The challenge in these ones is that you not only have to restore mid-face projection, which is what you'd have to do with all of our maxillectomy defects. You have to think about oronasal separation, prevention of oronasal fistula. You need a strong base for dental rehabilitation, whether it's implants or other dentures or other prostheses. But in this case, we also had to support his orbit. We had to find a way to allow his orbit to have a base so that he doesn't sink down with gravity and cause dystopia or vision problems. So here's what we did for his plan. I took one piece of the fibula and used it to align it along the orbital rim. And this was nice because I can sit there with the engineer again and overlay the preoperative CT and where the orbital rim was located, and basically precisely put that piece of the fibula at that same segment. And it also allowed us to create that 3D printed orbital floor plate, which I think would have been, again, difficult to sort of create or bend otherwise. And then that second piece of bone goes across the maxillary alveolus. That plate also is a wonky plate. I mean, there's two limbs to that plate that encompasses the whole thing, and it goes all the way around to the left zygomatic arch. So again, something that I probably would not have been able to bend otherwise. Here's a picture of what it looked like intraoperatively. You can see kind of here's the orbital plate right here. Here's the plate going over the fibula. Here's the pedicle, the vessels going out into the cheek. We actually had to do vein grafts for him. And here's what he looked like post-operatively. Overall, healed up pretty well. His final pathology came back as low-grade sarcoma. So not surprisingly, it was something malignant, and he is undergoing adjuvant radiation therapy currently. Here's what he looked like about a month post-operatively. He had a pretty large leg, and so I initially used the skin to reconstruct his palate, but it was pretty thick, so I took it off and I just used the muscle instead. And it's kind of nice because the muscle atrophies over time and it starts to granulate and mucosalize. And it actually kind of blends in pretty well with the residual maxilla. Here's another case of maxillary reconstruction, and this time this is using a different bone, the scapula, so you can do medical modeling with other bones other than the fibula bone. This is a 52-year-old. He had a gunshot wound to his palate about 10 years prior. He underwent numerous failed local reconstructive procedures. He had subsequently multiple oronasal fistula, and most of his hard palate bone was gone. He had a significant difficulty with speech and swallowing, and he really, wanted something done. And so for his case, we used the scapula mostly because the scapula tip has a nice shape to it. It kind of nicely mimics the shape of the hard palate. And it's a thin piece of bone. It comes with a nice bed of muscle. And in this case, with medical modeling, you can create an implant, a guide that essentially goes right over your scapula tip. And then you can see in this picture, we can fit it so that the bone rests right up against the pterygoid plates. And I think this is the nice part about it, is that mid-face projection can be exact. So with maxillary reconstruction, oftentimes we're sitting in the operating room on the side of the bed trying to figure out the level of the maxilla that the patient needs to achieve that level of projection again. And it's really inexact. There's a lot of swelling intraoperatively, and so we always feel like we're over-projecting somebody. But this is a precise way to put it exactly where you want it. And you could sort of mimic it against like a stock CT scan. In this case, he did not have a hard palate, so I did not know where to put it, but I could use an average CT scan to help us figure that out. Here's another kind of nifty use of that technology. This company was able to create a bone thickness heat map, and with this, it allows us to determine what parts of the bone have the highest density. So, when we're doing mid-face reconstruction, we can put everything in the right place. We get the plate in the mini plate or whatever plate we decide to use perfectly aligned. Go to drill our hole, put the screw in, and then start spinning. And sometimes that happens because the bone is just wafer thin. And this allows me to sort of plan exactly the location of the screws so that we have a nice, strong foundation for that screw. Here's a picture of what that scapula harvest looks like. Again, just I think has a lot of nice muscle there, and we use that muscle to reline that palate once the bone is inset. Here's what he looked like post-operatively. So again, I think he had pretty nice projection there. Probably would have not been as good if I had done it freehand. And here's what it'll look like intraoperatively or postoperatively inside his mouth. Still healing, but I think it's nice because the muscle, again, just atrophies. You get this mucosa that kind of goes right over the top of it. After a while, they start to, the mouth looks pretty normal looking. We do a lot of fibula skin paddles in the mouth, and those will always be, hairy. And it's pretty obvious that, there's something wrong with the inside of their mouth. But these muscle-only flaps actually look pretty good postoperatively. Here's another interesting application of medical modeling. This is a 25-year-old woman who had a ameloblastoma of her right mandible. And in this case, she already had right-sided chin and lip numbness. And so we planned her surgery, and based on the proximity of the tumor to the left mental foramen, I knew that we had to go just beyond it. And we didn't want to give her bilateral chin, lip, and chin numbness. And so we had the company create this guide for us that helps us figure out exactly where the inferior alveolar canal is. We drilled out that nerve, protected that nerve, kept it attached to the lip flap, and then we went ahead and made our cuts. And that's sort of the reconstruction there you see there. And I think this is nice because we were able to preserve at least sensation to her residual left-sided chin and lip, and I think that probably helps with speaking and swallowing. All right, in the last few minutes that I have here, I kind of wanted to talk a little bit about the criticisms of medical modeling and some of the research that has been done to look at some of these areas. I think the biggest criticism has been cost. Cost has been probably the main barrier for medical modeling. Cost has been coming down as there's more competitors in the field, as the companies are scaling their production, and as a lot of these manufacturing is coming into the United States, a lot of the cost has decreased over the last 10 years probably. But here's a couple studies looking at the comparison of either the freehand method or that medical modeling method. And the premise is that medical modeling saves operative time. And so these two studies here, this first one, Zweifel et al., was in Switzerland, and they saved about 67 minutes per case. And in their system, an hour of operative time costed about $2,800, which equated to about a cost saving of $3,200. And so they used that to sort of deduct it from the total cost of the case. And so in their system, to use medical modeling, it only costed them $3,200 extra compared to their traditional method. This next study, Lee et al., was in Virginia. In their study, they showed that they were able to save 2 hours per case. And in their system, an hour of operating room time, including anesthesia, ancillary staff, costed them about $4,600. So total cost saving about $9,000. And they were able to save about $5,000 per case. So I think these numbers are kind of all over the place. If the more you look at it, but I think there are opportunities to save money in terms of medical modeling if you're able to show that you can save time in the operating room. So bony union, I kind of showed you that you can make these really precise angles and cuts in your bone. The reason why that's important is because we want to really maximize bony contact to allow bony union. You do all that work on your fibula, and then you find out, a year later that there's non-union, and it can be devastating because then you have to think about, ways to fix that. So this is a good study that was out of Mayo Rochester. They looked at 250 flaps over a 20-year period, and they found that there was a 3% rate of non-union in medical modeling versus 17% in the traditional method. So perhaps better bony union outcomes with medical modeling. What they didn't talk about, and maybe something that can be looked at in the future, is does that lead to decrease in revision surgeries because of that better union? And that would obviously take down cost because of that. Does that allow for better bite force and, again, speech and swallowing outcomes? Another criticism has been, it takes time to get those models printed. It takes time to get the plates printed. And if you're dealing with cancer, are you allowing your cancer to grow while you're waiting for that? And are you in consequence having a higher rate of positive margins? So here's two studies that looked at that question, one in Australia and one in Germany. In Australia, they actually did not find a difference in the time that it took to take somebody to the OR to time that they saw the patient in clinic to the operating room. And then more importantly, they found no difference in margins. This German study, they did find that it took them a little bit longer, about 40 days compared to 30 days. But more importantly, they did not find a difference in margins. Here, it takes us, I think, around 30 days to get somebody from clinic to the operating room. You know, as soon as we see a patient, we'll get the scans rolling. It takes the companies about 2 weeks turnaround time to from the time of the scan to get all the implants. So it works out pretty well, I think, in terms of timing. The other thing I'll mention is that sometimes with medical modeling, like I mentioned earlier for the ORN case, it can be hard intraoperatively to know where your bony cut should be. And so I almost think that this helps me in a way to determine the bony cuts, because you can look at the CT scan, and if there's a subtle abnormality there, you can really push it, you know, beyond that to make sure that your bony margins are clear. And so here's another sort of future application of medical modeling. It's being done now, but it's sort of not widespread yet. Implants in fibula flaps are incredibly difficult. A lot of our patients will go on to get radiation therapy. Implants in a radiated flap have a slightly lower rate of success, and so there's a lot of hesitance in the community to implant fibulas. There's a lot of cost associated with it. Most insurances do not pay for implants, so it's out of reach for a lot of patients. This is a way to kind of bypass that. In using medical modeling, you can figure out the precise location of your implants. It sort of allows you to avoid your screws from your plates, allows you to have your implants kind of perfectly situated based on what your prosthodontist thinks. The other problem with this is that it does require a big team to be able to do this successfully. You not only need a head and neck surgeon, but you need an oral surgeon to do the implants, and then you also need a prosthodontist to be able to restore the implants and create the devices on top of it. So this is my last slide here. I think there's a lot of really exciting things about medical modeling, but I think there's a lot that we still need to learn. I think it's pretty clear that there's a savings in terms of operating room time and flap ischemia time, but it's unclear if that actually leads to better outcomes, so better flap success, better margins, better mortality, that sort of thing. I think it's also pretty clear that this is more precise. The angles are better, it's more accurate, but does that lead to better facial contour? Does it lead to actual better symmetry, better aesthetics? Implant success, the fibula, I think, is better positioned for implant success, but I think that research still needs to be done. And just like with anything that we do here, I think we need more patient-reported outcomes. Aesthetics, patient satisfaction, does it lead to better speech and swallowing? Is there a better bite force? I think all of this will help us improve the value proposition for doing medical modeling if we can look at some of these topics. That's it. Thank you so much. I'm happy to take any questions. Probably out of time now, but here's my email address. Thanks so much.
Thanks, Tito. I think we have a panel that follows, so that might be an opportunity to kind of open it up to questions for any of the talks. So we'll just move on now. And so next, it's my pleasure to introduce my other partner, Dr. Audrey Baker. I'm also here at the Department of Otolaryngology.
Let's see. Maybe I have to start it again. Well, thank you so much for having me today. This is so much fun to sit up here with some of my favorite people in the world. Dr. Ted Technos was the person that originally got me excited about otolaryngology and inspired me as a medical student to become a head and neck surgeon. So I'm so thankful for him. I'm also thankful for him to think really hard about all that big, boring stuff that it really, really affects us, but I don't have the bandwidth or interest to think about big hospital systems and shifts in financial responsibility. So I'm so thankful that people like Ted are out here to figure that out for us with us in mind. I don't have any disclosures for today's talk, except that I really love my job. I think it's so much fun to operate on people. I like the physicality of it. I like being able to treat patients with my hands. I know that sounds very cliche, but it's something that just brings so much joy to my life. But, you know, as we heard today already, the medical world is shifting. I mean, that is a lot of money that medical oncologists make. I don't think I really totally understood that. But a lot of my talk today is saying, yes, this is a team sport. We're so happy to work with our medical oncologists, our radiation oncologists. I think we all know at this point that cancer care is best delivered in a multidisciplinary fashion, but I want a spot at the table. I want a big spot at the table. And I want to make sure that we know as surgeons that we are relevant and we are needed. So that's my disclosure for today. I love being a surgeon. I have 3 kids to put through college, so I don't want all of my business to go to the medical oncologist just yet. The incidence of melanoma is rising faster than any other solid tumor in the nation. This is really shown best in the United States, but also in other countries with a vast majority of Caucasian population. Most of melanoma happens in the head and neck. Over 35% of tumors will exist above the shoulders, so this is our jam. Also, other cutaneous malignancies, basal cell carcinoma, squamous cell carcinoma, these 2 entities make up the #1 cancer diagnosed in the US among all cancers, among all comers. Interestingly, there's not a ton of research put into this. So even though it's the most common malignancy in the US diagnosed every year, it's considered an orphan disease. So there's not a lot of people who are putting a lot of time and thought or money, really, into studying these cutaneous malignancies. Most of these are also originating in the head and neck. So as head and neck surgeons, we have a serious relevance and role to play in the diagnosis and management of these patients. It would be crazy not to talk about the fact that immune therapies have completely changed the face of cancer treatment. Okay, so there are all these really beautiful pictures in the medical oncology literature describing how the immune system both reacts with other tumor cells, as in this first window, you'll see this is a PD-1, how a PD-1 inhibitor works. PD-1 is a receptor on a T cell that activates certain cytokines in the area so that the tumor cell can be killed. You can also affect the immune interface with tumor cells via antigen-presenting cells, which is something called CTLA-4 inhibition pathway. So with the advent of all of these immune modulators, it's really changed the face of patients who may not be able to have surgery. But surgery is still first, and I don't think it's yet passé, right? I think we're still at the table. Now, these kind of pictures used to only be in surgical manuscripts. If you would pick up a medical oncology journal, it would be all survival curves, maybe some Western blots, super boring pictures, right? So when you're reading an article, most people are reading the abstract, maybe they read conclusions, and they look at the pictures. So medical oncologists have figured out if you put gnarly pictures, then somebody is going to pick up your article and read it. And these are from medical oncology journals, right? So these are looking at horrible cutaneous malignancies. With the advent of immune modulation, all of a sudden, all of those go away. Of course, this is only at 3 months. They're not showing you what happens a year from now, but honestly, I'm not going to either with my postoperative pictures. Here you'll see a PET scan, a patient, we like to think about this like, oh, their PET scan is lighting up like a Christmas tree. This is a patient with metastatic melanoma, and after 3 months of immune therapy, his PET scan has all of the black spots have vanished. So these are really exciting things to put in your journal and to make medical oncologists seem super cool. But what I want to tell you is I still think we're cool. And if you Google, are surgeons still cool? The #1 hit that comes up are all of these Spotify lists that surgeons listen to rock music in the operating room. And if that is not proof enough, I included some surgical pictures of, this is me looking super cool in a bunny suit, coming in an emergency with our former resident, Dr. Nielsen, who's in the audience today. This is me during residency. I cut out some cheerleaders to really, cheer on my junior colleague to close that one faster. But really, what I'm telling you is that we are still relevant. And actually, if you look at all cutaneous malignancies, and it doesn't matter what pathology you're looking at, squamous cell, basal cell, Merkel cell, sebaceous cell carcinoma, any sort of weird oma that grows in the skin, you always consider surgery first. So even though there are so many other modalities, and they're fancy and they're exciting, and everybody likes to talk about them at Tumor Board, surgery, barbaric old surgery, is the mainstay of treatment for every single cutaneous malignancy out there. So you should think about it first and foremost. There are neoadjuvant therapies that you can use to, quote, make surgery easier, or, some people talk about salvage surgery, but any of those adjectives you're gonna put before surgery don't matter. Surgery is really the mainstay of treatment. So we are really still at the table in all of these discussions. The neoadjuvant conversation is interesting. That's been going on for a really long time. People give used to be standard chemotherapy to shrink a tumor to see if you can get your margins closer. Now it's immunotherapy to shrink a tumor. All of that is still under investigation. You're not sure if you have to resect to your previous margins or to the new margins. You're not sure if the cancer is shrinking concentrically or if you're going to have multifocal disease after you initiate cell death. So all of that's kind of confusing. And I would really consider thinking about each patient as a case-by-case basis. For truly unresectable disease, immunotherapy plus or minus radiation, these are wonderful options. But I would encourage you to think about what it means to be unresectable. And I put these 3 examples up. This is a patient who came to, these are patients that I see in my clinic. I see mainly cutaneous oncology and a smattering of other head and neck stuff. This is a patient who came to me who said that this had been growing over the past 2 weeks. Now, he, surprisingly, there were in his chart 3 years ago, he had also come to see a doctor for something on his nose. So I don't know if he actually means 2 weeks or like 2 decades. But this patient really did not want surgery. This patient has a basal cell carcinoma. Imaging at that point showed no medial canthal involvement, showed no bony involvement. I mean, for me, this is a slam dunk for either Mohs, if you have a very gung-ho Mohs surgeon, or just standard surgical excision in the operating room. You probably could get negative margins. As long as the patient didn't have any other, perineural invasion or perivascular invasion, you might not even need postoperative radiation. So for him, I would say, yeah, come on, this is resectable. This is gonna be fun. We're gonna put on our rock music. Our residents are gonna be prepared and ready to operate on you. And he was having none of it. He said, absolutely not. Don't touch me. Don't look at me. This is unresectable because I don't want anybody to resect it. So that is one version of somebody who's unresectable. So he is going to go on to get immunotherapy. He's going to go on to get radiation therapy, and we're going to hope for a cure. It's not 100% cure, as you all know. The best cure for all cutaneous malignancies is surgery first, if you can do it, followed by adjuvant therapy. This next patient is a patient with Gorlin syndrome. So these are patients with DNA mismatch repair defects along a few different genes, and they present in their early 20s with multiple and persistent basal cell carcinoma. They can also have some odontogenic cysts, which usually don't kill them, but the basal cell is a problem throughout their entire life. So you have to be judicious with the type of treatment that you're going to give them. We'll talk a little bit later about Araveg, which is a hedgehog inhibitor that many of these patients undergo, but that comes with a lot of side effects. And Araveg is not a cure for basal cell. It acts more like a prison guard, like it holds everything back. Sometimes it shrinks it, but the second you let off of Araveg therapy, nearly 40 to 50% of those patients recur. So you have to be judicious about when are we going to start Araveg therapy in patients with Gorlins, and when are you going to do a neurosurgical excision. And finally, this patient who has the biggest, baddest tumor, this was a horrible cutaneous squamous cell carcinoma that started on the lower chin and eroded posteriorly into the mandible. At first glance, if you look at these three patients, maybe this one you would consider to be the most unresectable. However, this patient did the best with surgery, with full surgical resection, with a complicated reconstruction, and with postoperative chemotherapy and radiation. So, when you're thinking about resectability, number one is consider surgery first. That means seeing a surgeon. You don't get to be deemed unresectable without seeing somebody who could resect you. And the second thing is there's lots of reasons that people could be unresectable. Maybe it really is unresectable, like you cannot get a margin around this thing. Or maybe they have other medical comorbidities, or maybe the patient, for their own personal reasons, do not want surgery. So it's a good consideration. I just want to briefly go through some surgical considerations for advanced melanoma, basal cell carcinoma, and squamous cell carcinoma. Those are by far the most common cutaneous malignancies you'll see in a head and neck practice. Again, melanoma surgery continues to be the mainstay of treatment for local disease, for regional disease, and for distant oligometastatic disease. If you can resect the tumor with minimal morbidity to your patient, you should. There are many other treatment modalities for melanoma. There's immunotherapy, systemic therapy. There's TVEC, which is an intralesional injection you can give to patients either with unresectable disease or in-transit metastatic disease. Radiation has kind of taken a hit in the melanoma world, but my radiation colleagues, I'll speak for them since they're not here, they want to remind us that actually melanoma can respond to radiation. So if you have a big field cancerization, or if you have multiple positive margins, you can consider radiation therapy. And there are other targeted molecular treatments that you can consider in patients for whatever reason cannot undergo other therapies. For locally advanced disease, this is a surgical disease. Even though they have a very advanced T stage, they may not have an advanced N or M stage, like this patient presented with a T4B, meaning very thick, ulcerated tumor of the medial cheek. You can consider a sentinel lymph node biopsy even for T4 lesions. Historically, we do them for intermediately thick lesions, but a T4 lesion will still give you really good data if you already have metastatic disease that you might not be picking up on a PET scan. Negative margins are best, but they're not necessary. Patients do better with microscopic positive disease following with adjuvant treatment than they do with macroscopic positive disease. So this patient underwent a very large resection. For these medial cheek lesions, especially in a very old person, they get a reverse facelift where you just take off the face and move it over. If you can close the preauricular wound, you can, but you don't need to. That granulates very nicely. In patients with a large cheek advancement flap, I try to make sure to bolster the flap with some periosteal sutures through and through the skin to either the anterior maxilla, the inferior orbital rim, or both. And that really helps prevent ectropion when the patients heal. This is the patient at 1 week post-op, and this is the patient at 3 months post-op. He did not have any metastatic disease in the sentinel lymph node that we resected, and he's undergoing immunotherapy anyway because of his advanced T stage. In patients with regional or distant disease, please still consider surgery. In patients with regional disease, a sentinel lymph node biopsy continues to be the gold standard to evaluate patients with a clinically negative neck. Now, this is the one area where surgery is falling out of favor. In patients with a microscopic positive sentinel lymph node, meaning that they have an intermediate thickness primary tumor, you've done a sentinel lymph node biopsy, and lo and behold, on final pathology, they have tiny little bits of tumor in the lymph node that you took out. The MSLT2 trial, for a long time, we used to do an elective neck dissection, a completion neck dissection, if you found metastatic disease in the node. However, over the last 5 to 10 years, that's really changed. With the publication of the MSLT2 trial, which is a large trial looking at patients with microscopic metastatic disease in the sentinel lymph node, observation or adjuvant treatment with immunotherapy versus elective neck dissection, there was no difference in overall survival. And while there is a very vocal minority of head and neck surgeons who continue to do a completion neck dissection for positive metastatic lymph nodes in the neck, most of us don't anymore. Most of us believe that data. Neck dissections are fun. I get why you'd want to do them, even though you don't need to. They're very, low morbidity. There's no lymphedema. It's the awesome operation to show the students. But honestly, with microscopic positive disease, you probably should not be doing a completion neck dissection in these patients with melanoma. Now, that's really the only time you're going to hear me say, don't do surgery. In transit disease, if you can get around it, you should resect it. Macroscopic regional disease. Sometimes a medical oncologist will say, no, leave that in there so I have something to follow. Have something to follow? That's crazy. If that's oligometastatic disease and I can take it out, we know that those patients do better with adjuvant therapy than they do just looking at it, okay? So take it out if you can. Now, if you're gonna have to cut somebody's whole head off, obviously don't. Let the medical oncologist do their $1 billion of revenue a year. But for each individual patient, you have to think about what's gonna give them the best prognosis. Even though you might not cure them, dying from horrible disease in the neck is a really horrible way to go. Also for oligometastatic disease, meaning like a tiny little bit in the adrenal gland or a tiny little bit that they find in the belly, take it out. Send them to your general surgeon and have them take it out. And we can, you can turn melanoma really into a chronic disease by treating them with immunotherapy and whittling away at them over the years. This is a very complicated algorithm to decide which type of immune modulation your patient might benefit from, but don't look at it, just send it to the medical oncologist and let them do their work. Basal cell carcinoma can be very, very locally aggressive. This is a patient who came to me with a multiply recurrent basal cell carcinoma after Aeroveg therapy, multiple surgeries, and postoperative radiation. Do a big surgery. Okay, everything else has failed. You're not going to hurt him. Look at this poor guy. I mean, having an exposed eyeball falling into your maxillary sinus is not a fun way to live. So I did a complete orbital exenteration. I put a submental flap into the defect, and it's not like a lot of people who look better with an orbital exenteration, but I really think he does. And he was much happier not to have his eyeball flying out in the breeze. Even my kids who were looking at this talk, that they were like, wow, he looks good, Mom. And I'm like, yeah, future head and neck surgeons, that's right. Aeroveg is a really wonderful drug. It's a hedgehog inhibitor. I will say that you can place patients on this for a limited amount of time. Patients do not tolerate this type of drug forever. They all get tired, they get rashes, they get diarrhea, they get muscle aches, and it doesn't work forever. What you're doing is you're providing a selective pressure for all of those cancer cells to move away from. So you can have these smoothened, they call them, it's a gene called the smooth gene or something, so that you can have these changes in the smoothened pathway, and then it makes Aeroveg not reliable anymore. And you'll see that in your patients. You'll have patients who will have been on Aeroveg for months and their tumor's shrinking, and all of a sudden it grows overnight. So then you do surgery again. This is a patient who had craniosynostosis, 70 years ago. Obviously, it didn't work. He still has kind of a funny shaped head here. But what you're seeing here, this is a very large basal cell carcinoma, and in the bottom of his basal cell carcinoma, I swear to you, it looked like tinfoil. But what he said was, no, this was the plate that they used when I was a child, and it was exposing, 60 or 70 years later. So he had a huge resection. We did a craniectomy. We took out the bone. We gave him a nice, hairy radial forearm flap. Sadly, I don't actually think that's good, but we thought it was fun to give him a little hair on his head just for a few moments until he got radiated. So this picture on the right is 4 years post-op, and you can see the flap has no more hair. The radiation took care of that. He's still disease-free, but now posteriorly, some more of that tinfoil plate is exposing. So I guess more surgery for him. He would not be eligible for any Aeroveg immunotherapy, obviously, because he's cancer-free at this point. This is one of those crazy pictures that now you're seeing in the Medical Oncology Journal. You can see this patient with a ton of in-transit dermal metastatic disease, which you have to think about like lung cancer. These patients are probably not curable, and he gets a few rounds of immunotherapy and they all disappear. There are patients, though, with squamous cell carcinoma and other cutaneous malignancies who cannot get immunotherapy. And mainly, these are patients with solid organ transplants. Now, there is a subset of medical oncologists who have been trying to give these patients immunotherapy with limited success in their organ. But this is a patient who had a double lung transplant. He had multiple Mohs surgeries. He was treated with postoperative radiation therapy. And he still has this confluent, multifocal disease that's really involving his entire cheek. So don't be afraid to do big surgery. We had a huge cheek resection. We rotated a submental flap, and at 1 week post-op, he looked okay, and at 3 months post-op, he was really happy because he got his beard back. So surgery is still awesome. Surgeons are still cool, whether or not you listen to rock music in the operating room. We have a major seat at the table, and I know it's fun to talk about all of the fun immunotherapies that are out there, but surgery is still the mainstay of care for all cutaneous malignancies. And I'll leave you with my home team demonstrating excellent sun protection. And if you guys go on the hike later today, make sure to wear your hats and sunscreen. Thank you. Thank you. You know what? That was here somewhere. Yeah.
Okay. Turn things back over to Dr. Teknos.
Thanks, Steve. So Audrey's always a tough act to follow, so all that energy, enthusiasm, positivity. But we have a common theme, and that's that surgery matters. So we're going to talk about larynx cancer, and I think larynx cancer has come full circle. So this, what I'd like to do is kind of go over the history of laryngeal cancer treatment and kind of what the current state is. So, larynx cancer, unfortunately, continues to have less than a 65%, advanced laryngeal cancer has less than a 65% survival rate, and that really hasn't changed since the 1970s. When you look at sort of this now famous paper that was written by Harry Hoffman, back in the 90s, what you can see is that all cancers' survival rates have gone up from 75 to 99 by about 14%, but laryngeal cancer survival peaked in 1980 and now is down about 5% to 60, 65%. And, there's certainly, an inflection point that happened in 1990 with the advent of the VA larynx study and non-surgical approaches to laryngeal cancer. So what I'm going to cover in this talk, and I think we're running behind, so I'm going to try to make up some time if I can, is talk about how organ preservation changed how we think about laryngeal cancer, talk about some of the long-term, the complications and emerging, morbidity from these, and then as surgeons, we really need to understand this data and continue to argue for surgical intervention when appropriate, and more it's becoming appropriate to do surgery on advanced laryngeal cancer. So we're going to, again, talk about these studies, and then another key important finding here is there's some ASCO guidelines that came out which actually are surgeon-friendly. And that's saying something, since ASCO is not a surgical society, but I think it's important for us to be aware of them. So, prior to 1990, as many of you know, most patients with advanced laryngeal cancer received a total laryngectomy or a partial laryngectomy if it was appropriate. But then, there were two major randomized controlled trials that sort of built this foundation that you can treat laryngeal cancer without surgery. And the first was the VA Larynx study, and the second one was RTOG 9111. And we'll go over that in some detail because I think some conclusions were drawn which weren't entirely founded by the evidence, which we can talk about a little bit. So this is the VA Larynx study. I remember I started residency in 1991, and this study came out, and I'm like, oh, great. Now we're going to stop doing laryngectomies as soon as I become an otolaryngologist. Luckily, that wasn't the case, but certainly it ran through my mind as a fledgling young head and neck surgeon. And then in 2003, the RTOG 9111 came out, so we can go over those and talk about current findings. So here was the headline from the VA Larynx study, which came out, as I said, in 1991. It's that treating patients with upfront total laryngectomy is equal to doing induction chemotherapy followed by radiation therapy. So my former mentor, Dr. Baker's, and as well as Dr. Wong's teacher, Dr. Greg Wolf, was the PI on this study. And the conclusion of that study is that survival was equal whether you had induction chemotherapy first or a total laryngectomy first. And in these induction chemotherapy radiation patients, 64% of patients were able to preserve their larynx in the non-surgical arm. Obviously 0 in the surgical arm, but 64% in the surgical arm were able to preserve their larynges. So who were the patients? So they were, stage 3 and stage 4 laryngeal cancer patients, and there were two arms. First arm was total laryngectomy followed by radiation, and then the comparison arm was induction chemotherapy, and there was an assessment of the tumor. So the tumor had to shrink by 50% or more to go on to receive radiation therapy. If they didn't, then they would receive a laryngectomy after this non-response to treatment. That was kind of the way the study was set up. So that's what I just described. Chemo, you assess the response, has to be 50% or greater. And then if it was, they went on to radiation. If it wasn't, they had a total laryngectomy. So these patients were primarily, if you look here, so there was 332 patients. They were primarily T3 patients, and they were primarily in the supraglottis. That's where most of these patients had their tumors. There were a fair number, 85, or about a quarter of the patients that were T4 under this staging guideline. So any cartilage invasion was deemed T4 then. Now it has to be cartilaginous. But back then, even inner table was T4. And you can see the nodal status, and then the number of patients who were Karnofsky score less than 80 or greater than 80. What you see here, and this is the graph everybody puts up and made medical oncologists jump for joy, is that surgery and induction chemotherapy had equal survival rates at 5 years. And there was no difference between the two. So, but the sad thing is that the 2-year overall survival rate was only 68% for all patients in this study. So at 2 years, only 68% of patients were alive. And there was a tendency to have better disease-free survival in the surgical arm, but it didn't reach statistical significance. So, keep that in mind. And here's how patients failed this treatment. So there was more local recurrence in the chemotherapy group. There were distant metastases that were higher that occurred in the surgical group, and Greg Wolf used to always argue sprinkling in some chemo prevented distant metastases, and I think he still believes that. And there was no difference in the regional control. But 64% of patients preserve their larynges. This is, simple math here. So 36% of patients required a laryngectomy in the chemotherapy arm. So 36% required laryngectomy. But what was interesting, though, is in this study, and this was left out of the discussion, of this 36%, 29% either had it prior to starting radiation therapy or within 3 months of completing radiation. So it was early salvage. The overwhelming majority of patients had their larynges taken out early, prior to radiation. So that survival rate is a bit misleading because they had early laryngectomies, then radiation, and they were included in that chemotherapy arm. So this is a very important part of the VA larynx study, which is kind of lost in the fog, is that most of the laryngectomies were done before radiation or within 3 months from the completion. And again, this is the overall survival, but as I mentioned, the chemotherapy arm included patients who'd had laryngectomy right at the beginning. That just, further makes that point. Now, the other thing that was left out of this discussion is even with this, sort of more liberal T4 inclusion, where even internal table was counted as T4, the laryngeal preservation rate in the VA larynx study was 44% in the chemotherapy arm. So, a significant proportion of patients, 56%, required a laryngectomy if they had a T4. Now, how bad is 56% laryngectomy rate? To put it in perspective, it would be like putting the likelihood of you saving your larynx in the hands of Shaq making a free throw, because his lifetime free throw percentage rate was 52%. So I don't know about you, but I wouldn't want my larynx determined by Shaq making a free throw or not. And you can see this is when he played for the Suns. I put it in for you guys here in Arizona. So a bad laryngeal preservation rate for T4 patients on the VA larynx study. So yes, survival was equal, but this was a highly controlled environment. Patients were followed in an academic medical center. They had endoscopies, operative endoscopies after chemotherapy with biopsies to confirm response and measured response rates. And they had early laryngectomies in the study, which again is very important to consider. And it was really, in essence, a chemo selection protocol, trying to figure out who were those patients that responded to chemotherapy so that they could have radiation therapy alone. So the medical oncologists really ran with this because they said, well, it doesn't compare to concurrent chemoradiation therapy, and it didn't show a superiority to the non-surgical approach. So the follow-on study then that was designed was RTOG 9111. So this study, its primary goal, it was published in the New England Journal of Medicine, and the primary goal of this study was to determine how much chemotherapy contributed to radiation as laryngeal preservation treatment. There was no surgical arm in this study. So these were the arms. Again, it included stage 3 and 4, but it excluded large volume T4. So they learned that fact from the Shaq free throw. But, they had the induction arm with so they called this the VA larynx arm, but they didn't do early surgeries in this arm. They also had the concurrent chemoradiation arm, which was, the arm of investigation, and then they had radiation therapy alone. Now, at Michigan, we didn't participate in this study because this is unethical, frankly, treating radiation alone for stage 3 and 4 laryngeal cancer, so we refused to participate in this study. A lot of others did, There were, nearly 500 patients in this study. And, the makeup, as you can see, is primarily supraglottic cancers, again, that were T3s. A pretty evenly matched set across the different arms. Now, what this did show is that when you did concurrent chemo and radiation therapy, the laryngectomy rate was 16%. So that is a much better laryngectomy rate in the concurrent chemo radiation arm. Whereas, the induction arm, remember, we talked about a 29% rate of laryngectomy that was early. It ended up being about the same amount, 29%, but it was done late. They weren't done early, these laryngectomies. And the radiation therapy alone arm had a 34% rate of laryngectomy. Local control was also better with concurrent chemo and radiation therapy, with a failure rate locally at 31%, whereas you can see radiation and induction chemotherapy, about half of the patients failed local regionally in this study. So when you looked at the conclusions, it was that concurrent chemoradiation therapy was best, induction followed by radiation was second best, and radiation therapy alone was the worst for both local regional control and laryngeal preservation. There was a significant advantage for concurrent chemoradiation therapy for laryngeal preservation and local regional control, but induction chemotherapy was found to be no better than radiation therapy alone in these two areas. Interestingly, though, if you followed all arms out, the 5-year survival rate was identical. At 5 years, it was 55%. There was no difference in any of these arms, even though the laryngectomy rate was lower in the concurrent chemotherapy arm, and the local regional control was better. But 5 years, no difference. But what was different, which is very important, is that patients who received concurrent chemoradiation therapy were twice as likely to die of other causes than patients who were in either the induction arm or the radiation therapy alone arm. And this, although they didn't specify it, is very likely aspiration pneumonias and complications of the treatment itself. Also, what you can see is that the cause of death, with cancer were higher in the induction chemo and radiation therapy alone arm. So overall survival was the same, but these patients died of other causes, whereas these patients died of cancer. So is it true that there is no harm in first doing concurrent chemoradiation therapy and then salvaging the patient with the laryngectomy afterwards? And that is not true, because this sort of famous study that was done by Dr. Forestier as well as Randy Weber and others showed that salvaging patients following chemoradiation therapy had a much poorer survival than if they didn't recur. That makes sense. But the real question is, what about if they had their laryngectomy up front? Nonetheless, it's not equivalent to say, well, we'll try this and then we'll salvage you if it fails. So some take-home points: concurrent chemoradiation therapy is superior to induction chemo and radiation, but they all had similar survivals at 5 and 10 years. No surgical arm, though, which is crucially important. The induction chemo is no better than radiation, had no impact on local regional control, and there was worse survival in the chemoradiation therapy arm in those who required laryngectomy, and more patients in the chemoradiation arm died of other causes. And it's not true that there is no harm in first trying chemoradiation and then salvaging the patient. It did not show that. And it did not show us how to manage T4 disease or T1 disease, because those were both excluded. And T1 with neck disease is the real question there. But I think, well, let me make this point. Also, it showed that there was a superiority of non-surgical approaches. Oh, what it did not show was that there is a superiority of non-surgical approaches to surgical approaches. However, that didn't stop the authors from saying Laryngectomy should only be performed as salvage therapy. We believe that most patients with laryngeal cancer, the disease can be managed without primary surgery. It's in the New England Journal of Medicine. Nobody has apologized for this comment to date, but it is grossly inaccurate, and you'll see why. So, if you follow since the 90s, the incidence of laryngeal cancer has been decreasing steadily, but the death rate, according to in laryngeal cancer patients, has decreased, but only slightly. Certainly not at the same slope as the death rate as the incidence in laryngeal cancer. So, these are the take-home points that I wanted to make. 56% of T4s still required total laryngectomy in the VA larynx study. Of the 36%, 29% of them had it early, their total laryngectomy. And then RTOG 9111 didn't include T4 disease, and we talked about the other things. So what do we do, or what's the current recommendation that that ASCO has given us with regards to practice guidelines for laryngeal cancers? So this is a summary of it. This was published in the JCO, and it's the use of laryngeal preservation strategies in the treatment of laryngeal cancer. And the answer here will surprise you that some of these folks who were part of the 9111 trial have actually modified their recommendations over time. So for T1 and T2 disease, we think about those differently than we'll think about T3, T4, and how do we select patients. So for T1 and T2 disease, there's no question. The point is we want to preserve somebody's larynx if you have early stage laryngeal cancer. You want to do it as a single modality, and surgery and or radiation therapy are basically equivalent and have equal voice outcomes. So the new recommendation is that the primary purpose is to preserve a larynx in a T1, T2 disease. Surgical strategies result in greater than 90% long-term laryngeal preservation. And you obviously have, you have very important patient selection factors to consider. Why surgery? Like Audrey says, it's cool, but in addition to that, surgery is much, much less expensive than radiation therapy, and radiation therapy can be held, should the patient develop a second primary tumor, which we know in smokers, which many of these folks are, is not a rare occurrence. Why radiation? It is a single modality treatment. It should not be done in conjunction with surgery. So surgery with the anticipation of postoperative radiation is not an acceptable approach for these early tumors. So if you have an anterior commissure lesion that you're worried about getting close margin, you say, well, I'll get as much of it as I can out and then radiate it. That's not a reasonable approach. So radiation therapy should only be considered if you think you can't get the tumor out completely surgically without really worsening a person's voice. So these are equivalent, and this is the ASCO guidelines saying surgery is equal to radiation therapy there. But what about, T3 and T4 disease? Should we use, concurrent chemoradiation therapy, radiation therapy alone, or organ preserving surgery? And that really requires a multidisciplinary evaluation to figure out what is the best approach to preserve somebody's laryngeal function. So one of the guidelines in this ASCO recommendation is that for T3s and T4s, your best chance to preserve the larynx is to use concurrent chemoradiation therapy rather than radiation therapy alone, or induction chemo followed by radiation. So that's restating, the 9111 findings. However, that's just saying if you are going to use non-surgical approaches. There are plenty of opportunities for partial laryngeal surgeries for T3s at least. So for select T3s and T4As that have poor laryngeal function, and that's defined by folks who already are aspirating, have poor voices to begin with, there's better survival and quality of life with a total laryngectomy rather than organ preservation. And this, again, is part of these guidelines, which is a big leap for our for med and rad-on colleagues. So, again, evaluate a person's laryngeal function if they have T3, T4 disease, and if it's impaired to start with, do a total laryngectomy up front. We talked about this. 56% of T4s required a laryngectomy, and only 10% of patients had a T4 in RTOG 111. But this study that looked at 1,000 patients using laryngeal preservation therapy, and this is with T3s and T4s, versus primary surgery followed by adjuvant therapy, there's a clear survival advantage when you do surgery up front and adjuvant radiation rather than laryngeal preservation. It's about a 10% difference in survival that is consistent over the course of 10 years. So when your patient says, what is my most likely chance to survive? It's a total laryngectomy followed by radiation therapy. This study was by David Rosenthal from MD Anderson, which is a really nice study where he looked at treatment outcomes in T4s that were treated surgically and non-surgically at MD Anderson over 3 decades. What they found was that survival with a functional intact larynx in T4s treated with concurrent chemoradiation therapy was only 32%. So only 32% of patients at 5 years survived and had a functional larynx, and it was only 13% at 10 years. You know, that's certainly not as good as this, which you can see, you know, with a surgical treatment was 30% at 10 years. The other striking example here is patients treated, T4s treated surgically, had a much higher disease-specific survival and overall survival than chemoradiation therapy for laryngeal preservation. And this held up as well for T3s. So T3s that were treated surgically had a statistically significant improvement in overall survival as well as disease-specific survival if they had either a total laryngectomy or, you know, a partial laryngectomy for T3 disease. And it's even more striking for T4, as you can see there, for both overall and disease-specific survival. So part of these ASCO guidelines, taking all this into account, basically is stating that survival outcomes of chemoradiation therapy are inferior to surgery. So that is a bold statement, and surgery has better long-term disease control and function for patients with extensive T3 disease, and pre-treatment function is critical. So here's the new recommendation. All patients with T3, T4 disease should undergo voice and swallowing function counseling with regard to their quality of life, voice, and swallowing function. And better survival and quality of life occurs with total laryngectomy rather than organ preservation. I don't think a lot of our med-onc and rad-onc colleagues have read these guidelines, however. The other thing to state here is that pre-treatment assessments should really establish how functional the larynx is and the extended disease. And pre-treatment aspiration and non-functional voice, stenosis, favored total laryngectomy over chemoradiation therapy. This is a very interesting score here called the TALK score. So again, if a patient has a T4 disease, has nutrition or is malnourished, has an albumin less than 4, drinks more than 6 drinks a day, or has a Karnofsky performance score of less than 80, that would be a score of 4. A patient that has a score of 3 or higher has a 6% chance of laryngeal preservation. So if they're malnourished, if they drink, and if they have poor performance status, there's only a 6% chance of laryngeal preservation, so those patients clearly should have a total laryngectomy. Otherwise, there's really no validated markers that we can use to predict outcomes. However, size matters, so this is tumor volume in T3 disease. So the larger the tumor, the less likely you are to respond to concurrent chemoradiation. Peter Jangalewski, who's one of my fellows who's at University of Florida, did this study, and right at about 2.5 cubic centimeters is where the curve drops off significantly. So if you have a tumor volume that's bigger than 2.5 cubic centimeters, you're probably better off doing total laryngectomy or you know, supraglottic rather than chemoradiation. And this just shows, again, local regional control, big differences below and above 2.5 centimeters. And this just shows this in graphic form. And I want to leave you with this because I think this is a very important paper that was published out of Michigan. And it was nice that they included me in this because I had left like 6 years earlier, but I'm still on the paper. So that was pretty nice. Greg owed me one. But anyway, so what this study does is it actually looks at survival using bioselection with chemotherapy as a predictor of patients with advanced laryngeal cancer. And it was a well-done study, large study, and not surprisingly, what this showed is that disease-specific survival was best in patients who had a total laryngectomy. It was second best in patients who had neoadjuvant selection for concurrent chemoradiation therapy. So they used, you know, one cycle of cisplatin to determine response, and if they responded, go on to concurrent chemoradiation therapy versus chemoradiation therapy right from the outset. So overall survival was equivalent, but disease-specific survival was better with total laryngectomy. And what you can see here, which is very interesting, is that compared to definitive chemoradiation therapy, if you use neoadjuvant selection, a patient was 57% less likely to die if they responded to one cycle of chemotherapy. Stage 4 disease was twice as likely, or 2.5 times as likely to die. Glottic cancers had a much better survival rate, 40% less likely to die. Smoking played a factor, and certainly comorbidities. What was interesting, though, is nobody failed when non-responders, there were no failures in the non-responders to neoadjuvant chemotherapy that went on to laryngectomy. So what's next? What's the future hold? I think these are very important. You know, this talk score and using artificial intelligence to determine which treatment is best for laryngeal cancer patients is certainly the future. And then, you know, what are critical factors is you have to select the right patients for laryngeal preservation. They're becoming diminishingly small, the indications for laryngeal preservation, and you need active follow-up for these patients because not only do they fail, but their function significantly erodes over time. So here's the summary. Surgery or radiation for T1 and T2. For advanced T3 and T4 patients, you have to assess laryngeal function and you have to select the right patient for chemoradiation, but more and more, total laryngectomy is the right answer. And for T4s, surgery is always the right answer. And for poor laryngeal function, surgery is always the right answer. So surgery is making a comeback. And with that, I'll turn it over for the panel.
So while we're sitting up for the panel, I'll just open it up to anyone who has questions about any of the talks we've had during the head neck session. Yes, Dr. Kupferman.
total laryngectomy is the cheapest option.
Any other questions? Actually, I have a question for Dr. Technos, I guess, and we have three of us who've been to Michigan, and the data on bioselection is quite strong. Why isn't this caught on? And why aren't more people doing that?
Yeah, that's it. I feel like Steven Tyler carrying this. It's not. Oh, here it came off. All right. So, yeah, that's a great question, Steve. I think there's inherent biases. I think with different institutions. So, there's that. But I do believe that it's an intensive study that needs a lot of really close follow-up. So it can really only be done, in academic centers. So I think the challenge with all of these, and this is what happened with the VA Larynx study, is it was done at academic centers and at the VA, and then it was sort of distributed widely to community practices without a real understanding of all the intricacies of the decisions that were being made. So I think probably part of the reason that it hasn't gone on is what I said before. 75% of chemotherapy is delivered in private doctors' offices, and they just can't. They don't have the resources to do a study like that, even though it appears to be the right thing to do.
So, I think that's right. I think even when Greg Wolf talks about it, I mean, it's kind of a marker for the hope would be some better way of bioselecting our patients to predict, who is going to be the ones, the patients that are going to benefit most by an organ preservation therapy, and if they're not, then I think there's a lot of work that shows those are people that are better off going to surgery, but we don't have the 100% accurate way of determining that yet.
Yeah, I think the ultimate answer would be if we had a genetic marker or a signature, that sort of said these patients are going to be much better off having chemo versus surgery and the rest. That hasn't, there have been some markers that have done that. For instance, in breast cancer now, there is a panel of genes that predicts whether or not radiation is going to benefit you or not, and they're deciding now whether or not to give you radiation based on this panel. So I think that is the future, and really what this bioselection thing is just sort of a surrogate for that. So it'll probably come one day, but right now biomarkers are not mature enough to do that.
Okay, so I think we have a time for maybe one case, and so I'm going to have Dr. Borelli lead us on a interesting head neck case.
All right, so we just have about 10 minutes here. I wanted to present an interesting case of mine. This is a HPV oropharynx cancer case. So this is a 68-year-old man, astronomer, never smoker. He had a screening colonoscopy done about 8 years prior, and he had a colon polyp, colon SCC that was removed at that time. And so he was getting annual PET CTs. And then on these annual PET CTs, there's a little bit of uptake in his anus, and it was followed. And then about 4 years later, that uptake was increasing even more. They did a biopsy that demonstrated it to be SCC at T1N0. Then his care got a little bit delayed there because his mitral valve failed. He underwent open heart surgery. So 3 months had passed by. Eventually consulted with a GI medical oncologist to discuss treatment for his anal cancer. And on that visit, he noticed a new right neck lump. He got a repeat PET CT. This was just within 4 months of his prior one. And it showed this image, as you can see here. So brand new neck mass that was not seen on a PET CT just a few months prior. We got a core biopsy, and it showed a P16 positive squamous cell carcinoma. When I saw him on my exam, he had symmetric 1+ tonsils. His scope was pretty unremarkable. His exam was unremarkable other than that level 2 node. So I have a polling question here. Hopefully it works. It's the first time I tried this. So if you just text Arizona ENT to the number 22333, and that allows you to join the polling question, and you can submit your answer. So the choices are imaging alone, sorry, the question is, what is your workup to identify a primary in a patient with a P16 positive oropharynx cancer? Do you do imaging alone with a PET CT, MRI, or CT? Choice B, you proceed with imaging, and if you still don't know, then you go to pan endoscopy with directed biopsies. Choice C, imaging, and if it's still unknown, then you do a palatine tonsillectomy, and then you do biopsies of the base of tongue. Imaging, and then if you don't know, you do a palatine and a lingual tonsillectomy. All right, we got 2 results, it works. Give it 20 more seconds. All right, let's check it out. Okay. It does not show up on your screen, but it shows up on my screen. I don't know why. So it's 54% of people, so 15% for imaging alone, 8% for choice B, 50% for choice C, and 29% for choice D. Oh, there you go. Okay. So it worked. Interesting. So I want to throw this out to you guys and just see what you guys, what are your thoughts on primary workup?
I send these to you, doctor, so you can practice your tours lingual tonsillectomies with the residents.
And I appreciate that. Dr. Wong?
Yeah, so I mean, you know, P16 positive in this case, you know, I think one, it directs the unknown primary to being most likely in Wohldeyer's ring, most commonly either in the base of tongue or tonsil. You know, if there isn't any obvious imaging from the PET to direct you, the palatine tonsils are often a common sight, and you're going to get much higher yield. I usually quote between 70 and 90% if you do a palatine tonsillectomy as opposed to just directed biopsies. And in my hands, I'll usually do that with the robot.
Great. Dr. Technos, any other comments?
Yeah, I mean, I agree with D, you know, doing a palatine tonsillectomy as well as a base of tongue shave, you know, pretty low morbidity and good chance of finding your primary that way. What's curious, though, is obviously the anal cancer, which is probably HPV positive as well, so that could be his primary, you know, to begin with. But, you know, one thing you didn't mention is, you know, if that was HPV positive, it very likely is, and if, you know, if this is a homosexual male too, because there's a high rate of HPV positive anal cancers in that population.
Yeah, he was happily married. I don't think they did HPV testing on the anal cancer as far as I could tell, but I think they really thought that it was, especially after they found sort of this new head and neck cancer. Let me move on then.
And one thing I didn't see, I missed on the PET CT, what level was the?
Level 2.
Okay. Okay. So even, you know, even with that, I mean, you know, isolated level 2 P16 positive node, I'm still going to think mostly a head and neck primary. On the other hand, if it was a low level, you know, level 4, and they have a known potentially P16 positive other primary, then yeah, I think that's a good possibility.
Yeah, so we went on to get an MRI of his neck. We did not find a primary on that. His PET CT, I showed you before, just showed that neck node, but no other primary within the head and neck. And so we had a tumor discussion. You know, we talked pretty extensively about, you know, is this sort of a metastatic site from his anal cancer? And we thought that was probably unlikely just on the basis of how far away it was from his anal cancer. It was a pretty small T1 as well. And so we presumed that he had 2 separate primaries, a carcinoma unknown primary of his head and neck, and then an anal cancer. And we tried to figure out what the treatment strategy would be for him. So the options were to treat his anal cancer with chemoradiation therapy. In terms of his head and neck cancer, his options would be surgery or chemoradiation therapy. And then the following questions came up: should we treat both of them at the same time, or should we stagger them, do the anal cancer first and then the head and neck cancer, or vice versa? Any thoughts on that? This is probably more of a medical oncology question. I think what we had talked about was really that anal cancer treatment was much more rigorous and difficult to go through. And so, he was ready to go in terms of his conditioning, and we wanted to get him through that first. And so we planned to do the anal cancer treatment with chemoradiation therapy. We would then restage him, and then we would decide on the best treatment for his head and neck cancer after that restaging scan. So he went on to get definitive chemoradiation therapy with 5-FU and mitomycin for his anal cancer. And then about a month later, we got another MRI to restage him. And the top one is his pre-treatment MRI, so pre-anal cancer treatment MRI. And you can see sort of that right level 2 neck node. And this is the new MRI. So really no radiation therapy to the head and neck, just the 5-FU, the mitomycin. And you can see remarkable shrinkage of that lymph node. It's about 7 millimeters at that time. We got a PET CT, and there was complete resolution of that adenopathy. And then my repeat exam was pretty unremarkable too. Still no primary site, no longer able to palpate that lymph node. So we talked about it again at tumor board. What should we do at this point? Okay, and so this is my follow-up poll question. What would be your next step in treatment? Choice A would be would you observe him, do serial imaging and exams? Would you consider radiation and chemo to the head and neck? Technically was not treated, just only got the chemo for the anal cancer, but does not have any disease on your exam. At least it looks that way. Or do you proceed with surgery? Choice C with a torus palatine and lingual tonsillectomy, or choice D, torus palatine and lingual tonsillectomy for the unknown primary workup and a right neck dissection. All right, let's take a look. There we go. So interesting. All right, I'll throw it out to the panelists.
Yeah, I think, while it looks like he had a complete response with chemotherapy, it's 5-FU, that's one thing. Secondarily, too, it's very likely that node in the neck is going to grow over time. So, what I would proceed with is doing with D, doing the palatine and lingual tonsillectomies and a neck dissection, and I think that would be definitive treatment for him at this point in time. Anybody agree or disagree?
Yeah, I mean, A is really tempting, and after I saw the answer breakout, I thought, gosh, what was the question again? But I don't know, chemo alone kind of scares me for head and neck cancer, although there have been case reports that it does work. And I have had patients who have undergone similar treatments with a concurrent different type of squamous cell carcinoma who have been cured, as far as we can see, from their head and neck cancer, and who declined any further treatment. So it's not that it never happens, but it kind of makes me uncomfortable to not do anything else.
Yeah, and I think we all have those kind of anecdotal patients who have gotten a great response. But I think the answer is D. I think as long as the patient is a reasonable candidate for surgery, it's fairly low morbidity. And if it turns out that all the nodes are negative, everything's negative, I mean, I think then that's great news for the patient. But I think that's really the correct way to go.
You know, an interesting thing to think about with this is, you know, there is this abscopal effect in the immune, you know, therapy world where if you treat a MET or even a primary with radiation or some cytotoxic agent, it releases neoantigens, and then you prime the immune system to that, especially a virally induced cancer like this. So it's possible, you know, that the definitive treatment, you know, of the anal cancer primed the immune system, and that has controlled the head neck primary. But again, it would be a leap not to do anything, you know, at this point, I think, until you have more proof.
Yeah, so it was incredibly tempting just to watch him, especially after looking at that PET CT. But we did do a TORS lingual palatine tonsillectomy and a neck dissection. His pathology did not show any carcinoma in the specimen, in the tonsil or the base of tongue. And then the lymph nodes were all negative. So they could see that there was treatment effect there, but there was no viable carcinoma. So we took him back to tumor board, discussed it. We decided that observation would be his best strategy going forward in terms of adjuvant therapy. I don't know if we have time for more questions at 12:35 here, so maybe just a brief comment on maybe Steve, what your follow-up plans are in general for your HPV or pharynx cancer patients.
Yeah, I mean, so I think you've followed out the sort of NCCN guidelines, which, you know, I think are pretty reasonable. Really, the issue is hard to find, you know, actual definitive proof that any of these things are actually, you know, effective, but they're pretty reasonable. I think, you know, getting at least a baseline post-treatment cross-sectional imaging study of the head neck is pretty much something that everyone should agree on. Whether you continue doing sort of serial surveillance scans after that initial baseline study, if that's all negative, you know, I think is controversial. I think in practice, a lot of people do. But I certainly would agree with, at minimum, getting a post-treatment, either a PET CT or CT neck and chest to evaluate the head neck cancer.
You know, one thing that, you know, that I just thought of that would have been interesting would have been to do cell-free DNA for HPV after the initial treatment to see if it was zero. And, you know, that would give you a better sort of, a stronger case to observe. But, you know, I would add this as a potential surveillance strategy, you know, looking at cell-free DNA as an early predictor of response or recurrence for these patients.
Yeah, absolutely. So, I mean, I think ctDNA, HPV, ctDNA, I think if we had that available for this case, I think would have been perfect. And I totally agree. I kind of have one slide at the very end talking about that. 3 months post-op, I did get a PET CT. There was a small little FDG avid nodule in right level 2, right in that area that I had just previously dissected. He also had some uptake in his right vocal cord. And I scoped him. It looked completely normal. I did an FNA of that nodule, and it was negative. We were suspicious enough that I repeated the FNA a few months later, and it was still negative. And so we got MRIs every 6 months, really to look at that nodule because he had sort of a bizarre history. And the MRIs were negative. That nodule kind of stayed put, didn't really change. It was actually hard to even tell sometimes that it was there on ultrasound. I scoped him every 4 months, you know, just to make sure that we weren't, you know, finding the primary present itself. And about 2.5 years after that chemotherapy, radiation therapy for his anal cancer and then surgery for his head and neck cancer, this is just about a couple weeks ago, I noticed a new papillomatous lesion right in his right piriform sinus, about 1 centimeter in size. It looked pretty carpet-like, not exophytic, very indolent in appearance. He also had a right neck level 2 node that was about 1 centimeter in size. This time it was palpable, and I could see it on ultrasound. We did an FNA, and still awaiting the biopsies of that, but I'm assuming this will be HPV positive squame, and probably may have been his primary site all along. And so I'm planning, so he's sort of in the midst of getting his treatment plan for this, but he'll likely get radiation therapy and cisplatin for this head and neck HPV oropharynx cancer. Just a brief slide just about chemotherapy alone for these types of patients. Still being studied. There's one study that's looked at this, a neoadjuvant trial with cisplatin docetaxel. And basically, this trial is looking at if there's a response over 80%, then they'll go ahead and proceed with TORS and the neck dissection, and CRT if it's inadequate. And the long-term data is not published yet, but they basically found that in 54 patients that they were able to observe on this trial and actually off the trial, they found a complete response in about 44% of these patients. But again, that long-term data is still not available. Just on an abstract of that data, they found about in 20 patients, 3 of them had local recurrence and 3 of them had distant metastasis. So probably not equivalent to what we have in terms of our survival data for oropharynx cancer, which is 90+%. But I think pretty promising that perhaps you could use this data to de-intensify some of these patients. And then the last slide I have here is on ctDNA. I think this case would have been perfect for that. This is a study from my co-resident, Dan Faden at Mass Eye and Ear, who looked at a group of patients and performed TORS and a neck dissection. And he was able to find one patient, in that case series of 11, and detect early recurrence by using that ctDNA. So this graph kind of shows 2 sample patients. The one in blue underwent surgery, had positive margins, had positive lymph nodes, and so the ctDNA was still elevated post-op. And this is the start of adjuvant chemoradiation therapy, and then it plummeted pretty much to 0. But over time, it crept back up, and it sort of predated the actual biopsy that confirmed the actual recurrence. And then the one in red is really what they expected in a patient who had negative margins, 1 positive lymph node, but no E&E. ctDNA went to 0, and it kind of stayed that way. So I think in this case, that would have been kind of nice to use. Hopefully that, I predicted that would have been elevated probably all throughout his case and maybe would have tipped us off in terms of recommending treatment earlier for him. That's it. All right, thank you. Let's see, hello? Yeah, okay. No, she was not. There's currently no recommendations to screen the wife. I mean, I think that what I tell my patients is basically that you are exposed to HPV pretty early on for most people. And for his wife, she likely had exposure to HPV, whether it was from him or from someone else prior. And most people's immune systems are able to clear it. There's a small minority of patients who don't clear the virus, and then even within that subset, a small minority go on to develop cancer. So to have that data, if we knew that she had HPV currently, it wouldn't change what we do, and it wouldn't change our, we wouldn't, I guess, recommend like a prophylactic tonsillectomy or basic tongue resection based off that data. So yeah. Oh, no.